Before we get started, I would like to deliver some announcements for participants. Firstly, today's conference consists of one plenary lecture given by 4 speakers, and afterwards, the participant can enter the Hall A or Hall B to join parallel meetings. Secondly, if you wish to ask the presenters a question, you can directly type into the chat box provided in the lower section of your screen. Just scroll up to see it. You can mention the presenter you wish to ask specific question to. The mentioned presenters will answer the questions submitted, and the rest of unanswered questions will be replied through emails. Please note that it is not mandatory for the participant to type present in the chat box, since your presence will be recorded automatically by the system. We also invite you to participate in our sponsors presentation at the end of the sessions and visit their booths at exhibition halls in the website. On behalf of our organizing committee, I would like to thank our supporting partners for this event, PT USGH, GE Healthcare, Simon Headliner, Philips, Mulia Husada Jaya, Fuji, Murti Indah Sentosa, Mindray, Esaute, Sinergi Medika Utama, Sona Medica Jaya, and Infinite. Thank you for your continuing support. Please note that minimal 80% of conference attendance and complete booth visiting are required in order to receive the certificate with Indonesian Doctor Association credit for this event. If you experience any issues during today's webinar, please contact us through email or WhatsApp as attached in the website. Our support team will help you troubleshoot any issues. A recorded version of every sessions of these scientific meetings will be available as video on demand at the website. Can be accessed using your username and password until 17 October of 2022 or 1 month after this meeting. And now we will see some videos about this conference meeting and next year IMS meeting in China, website tutorial, and Balinese dance video before we enter the plenary session.
AMS, Asian Musculoskeletal Society. Asian Musculoskeletal Society is a wonderful society, bringing together radiologists and other specialties in MSK imaging, the Middle East to the Far East. The basis of the AMS is to share our love to MSK imaging with our friends from the Asian countries. Enhance education, training, and research into MSK disease. AMS is the biggest musculoskeletal society in Asia. AMS has 28.4 members from all of these countries. How to become AMS members? Please complete this following document or application form you can get from www.amsmsk.org, current curriculum vitae, recent photograph, and one email reference from a referee who will be assisting AMS members. And send this following document to AMS secretary email ams.secretary1@gmail.com. Pay membership, and finally, your name will be added to AMS membership list, and you will get the AMS certificate in your email. The AMS event will give you excellent speakers, latest development, hands-on session and imaging workshop, and participant benefit. And now, we will invite you to this upcoming event, Asian Musculoskeletal Society in Hainan, China, 13 to 15 September 2023. Please come and join us.
Good morning, ladies and gentlemen. This is the demonstration of how to use the application in our website. First, you have to click this link, which is sent to you via email from the organizing committee, and log in using your username and password. And then you will be redirected into our website. You can scroll it down and go to event. Click here, and you will be arrived at the lobby. There are several clicking buttons at the lobby, and you can explore your preference by clicking the click buttons. You can click information button if you need some assistance or you want to download your certificate. Scientific session will be held in Hall A and Hall B. The plenary session will be present in Hall A, and breakout session will be present in Hall A and Hall B. You can click Hall A to join the presentation from the speaker. You will find the big screen here, and you can click the full screen using the button here. If you have some question, you can back to normal screen again and scroll it down. Then you will see the chat box here. If you want to make some question, you can type your question in the chat box and send it to the speaker. The speaker will answer your question in chat box as well. And then if you want to go to lobby, you can click here. You can go to Expedition Hall by clicking the Expo Hall button. And you will be redirected into Expedition Hall, and you can click this button to get information from the sponsors. You can see several buttons here, and you can click them one by one to see the information from our sponsors. If you want to back to Expedition Hall again, you can click here and click other button of our sponsors. If you want to back to lobby, you can click here again. If you want to see poster exhibition, you can click the button here. And if you want to see the paper presentation, you can click this button. The paper presentation slide can be accessed several days before Perami. Please enjoy this meeting, and thank you very much for your kind attention.
The opening session is now completed. Without further ado, let's welcome our first speaker for plenary session, Dr. Paulus Raharjo. Dr. Paulus Raharjo is an MSK consultant, radiologist and lecturer at Department of Radiology, Airlangga University, Surabaya, Indonesia. Dr. Paulus will conduct a lecture about the important role of radiology in fighting osteoporosis. Dr. Paulus, the time is yours.
Very good morning, ladies and gentlemen, dear colleagues. Thank you for a nice introduction. Today, I will open this plenary session by sharing with you the important role of radiology in fighting osteoporosis. My outlines are like this. Let's begin with what is osteoporosis and learn about the burden of osteoporosis in the individual or in a community, and the role of radiology in fighting osteoporosis. Let's start with the definition of osteoporosis. The modern definition introduces the importance of bone quality or microarchitecture. The new definition classifies osteoporosis as a disease, not just a consequence of aging. Thus, clinically relevant parts of the definition are bone mass and fracture. And now we can make diagnosis of osteoporosis with the new definition even before fractures happen to our capability of being able to measure bone mineral density. Osteoporosis usually do not cause any symptoms unless it's fracture. And it's called fragility fracture, which is fractures that result from mechanical forces that would not ordinarily result in fracture, known as low-level or low-energy trauma. The World Health Organization has quantified this as forces equivalent to a fall from standing height or less. Let's see the burden of osteoporosis and the consequences of fragility fracture in an individual. Worldwide, the prevalence of osteoporosis is around 200 million people. And the incidence of hip fracture projected to increase substantially by the year 2050. 240% increase in women, but especially also increase in men more than women. And what numbers of worldwide increase especially happen in Asia. The number of hip fractures will increase from 1.7 million in 1990 to 6.3 million in 2050. The vertebral fracture. X-ray gives examples of vertebral fracture. And this graph is showing that the rising incidence in women beginning around age 50 and in men beginning later, around 10 years later. Vertebral fracture is most common osteoporotic fracture. And vertebral fracture is a marker for future fracture risk. Many occurs in everyday activities like lifting, pushing, or pulling. 25 to 30% of vertebral fractures seen on X-ray are diagnosed clinically. And patients with clinical vertebral fracture may have severe pain and are confirmed with X-ray. The next fracture, number 2, is hip fracture. There are two major types of hip fracture, femoral neck and intertrochanteric. About equal incidence, about 40%. Other hip fractures include femoral shaft or subtrochanteric fracture. The graph shows the rising incidence with age in women beginning at about the age of 60 and men beginning at about the age of 70. Hip fracture is a marker also for future fracture. Mostly are caused by fall from standing height. Only about 5% are spontaneous. Only 1% of falls lead to hip fracture. Not all falls lead to hip fracture. Diagnosis, most are diagnosed clinically, often confirmed with radiography. Most are hospitalized and require surgery. What is the complication of this fracture? Up to 24 to 30% there is excess or increase in mortality within the same year. And 50% of hip fracture survivors are permanently incapacitated. And 20% of hip fracture survivors require long-term nursing home. This is a silent killer. The 5-year excess mortality is about the same after hip fracture or after vertebral fracture. The mortality comes early after hip fracture, almost in the first year, and more gradually after spine fracture. Reporting osteoporotic fracture is important. Radiologists need to be sensitized to the fact that the presence of fragility fractures will alter patient care, and these fractures need to be described in the report. Besides the increase of the incidence of fractures, 80% who have one osteoporotic fracture are neither identified nor treated for osteoporosis. It's underdiagnosis. In one research, in PA and lateral chest radiograph of 934 women above 60 years old, moderate or severe vertebral fracture were identified in 14.1%. But only 50% mentioned in the radiology report, and only 1.8% of the 934 patients had a discharge diagnosis of vertebral fracture. As a consequence, few of these patients with vertebral fracture receive appropriate osteoporosis-specific pharmacotherapy to prevent further fracture. When you have vertebral fracture, for instance, because of osteoporosis, if it is not diagnosed and treated, the relative risk of future vertebral fracture is 4.4 times. This proves that the importance of reporting these fractures as osteoporotic fracture. Yes, osteoporosis can be defined by presence of history of a fragility fracture. But we want to use DXA, bone mineral density, for our advantage because densitometry can diagnose osteoporosis before fracture. So early detection of osteoporosis, calculating the risk of fracture and monitoring treatment, we are going to use BMD DEXA, stands for bone mineral density dual X-ray absorptiometry, to diagnose, to assess fracture risk, and to monitor treatment. And WHO has classification of postmenopausal osteoporosis with T-score, either from spine or hip. And if spine and hip cannot be used, we can use forearms. In 1994, WHO study group, a group of epidemiologists compared data from different countries and proposed a standard of diagnosis using T-score. But we can use DXA and clinically expand your measurement of bone density. We can use it to assess the vertebral fracture and bone architecture. We can use it to improve fracture risk assessment and guide treatment. As we all know, Janan has proposed a category classification for vertebral fracture, and for quantitative morphometry, we can identify four corners at the center of horizontal upper and lower border of the vertebra to identify vertebral fracture. And when we compare different techniques and detection on evaluation of vertebral fracture, vertebral fracture assessment by DEXA is quite good in resolution, low in radiation, and in certain countries is quite high in availability and convenience and patient friendly. And of course, the cost is usually less than CT or MR or nuclear scan. We can also assess the fracture risk by using tools that are supplied in PMD DEXA machine. We can use local database even, and here are the results. Fracture risk estimation is being used to make intervention recommendation, especially for high risk. If the risk is about 20% of all major fracture in the body, we can start the pharmacological treatment of osteoporosis. Now, we can also use trabecular bone score to assess bone quality. These two patients have the same T-score in bone mineral density. But as you know, the average spreading of the trabeculae in the upper patient with trabecular bone score is higher than the lower. Yes, there are thick vertical trabeculae, but a lot of holes beside the thick trabecular pattern. Then the trabecular bone score is less, even though they have same bone mineral density. The risk of fracture in the second patient is much higher. And now we can adjust our fracture with trabecular bone score to improve the accuracy. Radiology can detect adverse reaction to osteoporosis treatment. Atypical femoral fracture is a common complication of long-term use of biphosphonate. And radiographic views in figure A as an atypical femoral fracture that occurs spontaneously in women after 6 years of treatment with biphosphonate. And B, an incomplete atypical femoral fracture with cortical thickening that presented as a thigh pain. Research and AI and osteoporosis. There are lots of research to learn, to adopt, but also we can start our own research, especially using AI on osteoporosis. This is one of the examples of research with thoracic bone mineral density derived from cardiac CT is associated with greater fracture rate. And using AI, a fully automatic osteoporosis screening in routine CT with AI of the spine is feasible now. Using opportunity osteoporosis screening of spinal bone measures derived from clinical routine CT, like previously mentioned, like cardiac CT, is feasible in fully automatic fashion using deep learning driven framework. And manually sample volumetric BMD and automatically assess trabecular and integral volumetric BMD were the best predictors for prevalent vertebral fracture. Except for bone mineral content, all CT-based bone measures perform significantly better than DXA-based measure. And even this research introduced diagnostic threshold with diagnostic cutoff of integral volumetric BMD for osteoporosis is less than 160 milligram per cubic centimeters. And low bone mass as 100 equal to less than 160, or what I mean is low bone mass is between 160 and 190, had sensitivity and specificity of 84, 41%, 78, 91%, similar to trabecular volumetric bone mineral density. This is another example of what we miss in clinical setting. A female 63 years old walking backward fall on both outstretched hands. Don't ask me why she walks backward. She thinks that it's a good exercise. What we can see is distal radial fracture in both wrists. And she was not treated for osteoporosis. There is no prior diagnosis that this could be osteoporotic or fragility fracture. Then we did a study, and yes, we can see that there is indication that there is an osteoporotic fracture with a high fracture risk assessment of 4.8. More on the hip, this is quite a high. So she might have osteoporotic with a low bone quality, causing a high risk for hip fracture in the future. So the radiology role in fighting osteoporosis is identifying and reporting fragility fracture, even when they are incidental and asymptomatic. Make recommendation or suggestion for BMD testing if clinically warranted, and do BMD examination well to have the best productibility, calibration, and precision assessment. Do vertebral fracture assessment that provides lateral view and semi-automated software for evaluating vertebral body morphology on the Janan semi-quantitative method of diagnostic osteoporotic vertebral fracture, and do fracture risk assessment tool. Use it to calculate the patient's risk of future osteoporosis. This is the Asia Pacific ISCD panel, and thank you for your kind attention. Please step up for bone health.
Thank you, Dr. Paulus, for bringing us a very insightful lecture today. For all participants who wish to ask questions to the presenter, please directly type your question in the chat box and the presenter will answer the question submitted. Second speaker for this plenary is Dr. Drusi Patel. She is a consultant radiologist at Gujarat Imaging Center, India. Dr. Patel will present a lecture about MRI of temporomandibular joint. Dr. Patel, the time is yours.
A very good morning. At the outset, I would like to thank the organizers of Asian Musculoskeletal Society for giving me this opportunity to talk on dynamic MR imaging of temporomandibular joint. So we are going to address this topic under the following titles. We'll have a look at the protocols. A very good morning. At the outset, I would like to thank the organizers of Asian Musculoskeletal Society for giving me this opportunity to talk on dynamic MR imaging of temporomandibular joint. So we are going to address this topic under the following titles. We'll have a look at the protocols, MR anatomy, what is TM joint dysfunction, we'll have a look at a few of the cases, and how do we report. So let's have a look at the protocol. For TM joint analysis, we need a surface coil, and it is important to take thin sections of 3 millimeter or less. It is necessary that we take a small FOV so as to cover only the TM joint. The MR sequences are acquired in 2 sets, in closed mouth and in open mouth position. The PD oblique sagittal and the coronal images are the most important sequences for evaluation, and they are acquired in both closed mouth and open mouth. Besides that, a dynamic BTFE sequence is performed during mouth opening as well as closing movement. So let's have a look. How do we plan? So if you see at the TM joint on the first axial image that we acquire, the condyle, the mandibular condyle is oriented obliquely. And therefore, we need to plan, if we plan the coronal slices like the routine coronal slices, then the TM joint coronal is not the true coronals. And therefore, we need to plan oblique coronals individually for right and left TM joint in this manner so as to obtain the true coronals for the TM joint. Now, once we have acquired the axial image as well as the oblique coronal image, the sagittal images are planned. So, a perpendicular to the mandibular, to the long axis of the mandibular condyle, we have to plan, and also align along the condyle and ramus so as to get an oblique sagittal image. One more thing that is to be kept in mind when we acquire the coronal images is to cover the area of coverage in closed mouth should go beyond the articular eminence. This is because that when there is open mouth images are acquired, then the mandible, it glides forward along with the disc beyond the articular eminence so as not to cut a part of the articular disc or condyle during the open mouth images. It's important that the coronal planning should cover from the extra-auditory canal to beyond the articular eminence. Now let's have a look at the MR anatomy. So a TM joint, it involves a mandibular condyle which articulates with the mandibular fossa, and the bony prominence anterior to it is the articular eminence. There is a disc which is a biconcave disc, and it has an anterior band, posterior band, and a thin intermediate zone. The disc is held in place by the superior and inferior retrodiscal layers. And there is, within the loose connective tissue, there are the neurovascular structures. The superior and inferior capsular attachments of the disc attach to the articular eminence and mandibular condyle respectively. And the superior and the inferior head of the lateral pterygoid muscles attach to the disc and mandibular condyle and help during the TM joint movement of jaw opening. So let's have a look on the MR image. This is the mandibular condyle. This is the mandibular fossa, articular eminence. The black black bow tie-like structure is the articular disc, which has a posterior band, the anterior band, and a thin intermediate zone. The posterior band should be as close as to 12 o'clock vertical drawn on the mandibular condyle. Now, if we look at the superior fibers of the lateral pterygoid muscle, they are inserted onto the articular disc, whereas the inferior fibers of the lateral pterygoid muscle insert onto the mandibular condyle or in the tissues between the disc and the condyle. The retrodiscal structures are better evaluated on the open mouth images, where you can see that it is basically loose connective tissue, bilaminar zone, which attaches the disc with the temporal bone, and there are neurovascular structures in this region. These structures may have an intermediate to mildly high signal intensity even on normal images. So how does the TM joint work? This is the initial closed mouth position that we have seen. At the beginning of open mouth, it is the digastric muscle which tends to contract, pulling the condyle forward. On the maximum open mouth position, it is the superior and the inferior lateral pterygoid muscles which contract, which will pull the articular disc along with the condyle, which will glide along the articular eminence. Whereas the retrodiscal structures will act as a restraint, preventing the disc from moving out of the joint. And in full clenching position, these pterygoid muscles, they remain in full contraction. So let's have a look at the dynamic images. When we look at the dynamic images, you can see that the mandibular condyle, it glides over the articular eminence from the mandibular fossa onto the articular eminence. The disc glides along with it, and you can appreciate how they move in conjunction. So, a typical classical closed mouth image where the posterior band and bilaminar zone junction is as close as 12 o'clock along the vertical drawn over the mandibular condyle. And secondly, the intermediate zone is positioned between the mandibular condyle and the temporal bone. On open mouth images, you can see that the disc glides along with the mandibular condyle and lies between the articular eminence and the mandibular condyle. Now, as you observe that the disc remains in between the mandibular condyle and articular eminence, so on the coronal images, the bulk of the disc has to be seen in between the temporal bone and the condyle on close as well as on open mouth images. If it has displaced anteriorly, then you would not see that bulk in between the condyle and the temporal bone. So let's have a look at the TM joint dysfunction and cases. So what is a TM joint dysfunction? It's an internal derangement wherein there is an abnormal relationship of the disc to the condyle. Precise localization of the disc is the most important thing in diagnosis of TM joint internal derangement. Initially, it is the disc morphologic changes occur. That is, there is loss of biconcavity. The disc may be rounded in shape, or it may get perforated or flattened, thin appearance, or may be crumbled or irregular. Later on, there is disc displacement, which can be anterior, posterior, lateral, or medial. Then on open mouth images, we evaluate the disc mobility. Initially, it will reduce on mouth opening and come to its normal position, but later on, it fails to reduce and remains in the abnormal position. And with progressive TM joint dysfunction, the changes of secondary arthritic changes set in. So we evaluate the TM joint under the following headings of disc shape, position, and displacement, evaluated on closed mouth images, disc mobility evaluated on open mouth images, and also looking for the associated features like the shape of the mandibular condyle, joints, and the joint status. So this is a typical biconcave disc with the posterior band and the posterior band laminar zone as close to the vertical, the intermediate zone, and the anterior band. The abnormal disc consists of, there may be disc thinning, or it may appear crumpled or irregular, or there may be a central fluid intensity defect, that is a disc perforation. Now, subtle hyperintense signal in the posterior band in otherwise preserved bow tie appearance is considered to be normal. Whereas usually the intermediate zone and the anterior band have a typical low signal intensity. Normal disc position, when the mandible is in closed mouth position and a vertical is drawn over the mandibular condyle, the posterior band bilaminar zone junction should be as close to 12 o'clock. That is considered as normal. So we measured this angle, and this angle less than 10 degrees was considered as normal. The problem with this was that 33% of asymptomatic people also had this displacement if we consider 10 degree as the cutoff. So Ramelsberg, he suggested that anterior disc displacement of up to 30 degrees could be considered normal to better correlate with the disc displacement and symptoms of TM joint dysfunction. Either ways, normal is the posterior band bilaminar zone as close as 12 o'clock, the intermediate zone positioned between the mandibular condyle and the articular eminence. Now the disc mobility is evaluated on open mouth images. We can see the examples of disc displacement with reduction, without reduction, and stuck disc. Let's have a look at case 1. A 14-year-old with pain during jaw movement on either side. So we look at the coronal images first. That is the site of the disc. On the sagittal images, you can see that the disc was anteriorly displaced and it makes an angle of more than 30 degrees with the vertical. On the open mouth images, it tends to return to its normal position such that the intermediate zone lies between the mandibular condyle and articular eminence. So let's have a look at the static images. That is the disc anteriorly displaced on closed mouth images. That is the disc on the coronal images, and it gets reduced onto on the open mouth images. Also note that on the coronal images, besides the bulk being centrally placed, there is some amount of the disc which is disproportionately more on the lateral aspect. So this is anterior and lateral, anterolateral displacement with reduction, which is evaluated on the open mouth images. Another thing worth noting in this case was that this is the articular disc. It has to be differentiated from the lateral pterygoid muscle attachments onto the mandibular condyle. These together, along with the displaced disc, they give a double disc sign. Now having a look at the right TM joint of the same patient. So if you see on the coronal plane, there is this disc which is anterior, seems to be not positioned between the mandibular condyle and the temporal bone. On the sagittal images, the disc is anteriorly displaced and lost its bow tie appearance. And on open mouth images, it does not get reduced and remains in the anteriorly displaced position. So let's have a look at the still images. So that is the displaced disc anteriorly and not reduced on open mouth images. So this is anterior disc displacement without reduction. That is how we put it in our report. Disc morphology lost. The first case that the left TM joint we saw first, which was anterolateral displacement with disc reduction. Left is anterior displacement without reduction and no secondary signs of osteoarthritis. Coming to case 2, 55-year-old female with pain during jaw movement on left side. Now if you see, on the sagittal images, there is an irregular crumpled disc which is anteriorly displaced. That is the insertion of the lateral pterygoid muscle giving the double disc sign. In the open mouth images, it remains displaced, so it is without reduction. But note on the closed mouth coronal images, the bulk is, besides being centered, it is also there on the medial aspect. So it is enteromedial disc displacement without reduction. So that is how we put it in the report, enteromedial disc displacement without reduction and markedly thin and irregular disc with double disc sign. So what is important to note, not only the oblique sagittal images are important, but the coronal MRI is important to comment on the medial or the lateral component of disc displacement. Now, another patient, where 28-year-old male, he complained of a recent onset of limited jaw opening with intermittent pain in left TM joint since 6 months. His jaw mildly deviated to the left side on jaw opening. So these are the closed mouth images where you can see that the posterior band is close to the vertical and the intermediate zone was positioned between the mandibular condyle and temporal bone. Whereas on open mouth images, the condyle has translated anteriorly, but the disc is in its position and the posterior band appears more globular in the and remains so in the mandibular fossa. So this is stuck disc. Look at the still images. That is the disc on closed mouth. On open mouth, the condyle has translated anteriorly. A limited translation is there, but the disc remains stuck in the mandibular fossa. And this is how its appearance was on coronal images. So this is stuck disc or anchored disc phenomenon, where the TM joint disc does not translate anteriorly out of the mandibular fossa onto the articular eminence, but remains there, stuck in the fossa. And this requires arthroscopic adhesionectomy. Coming to case 4, a 40-year-old female with clicking sound on jaw movement on either side. She had a single episode of jaw locking in open mouth position. So if we have a look at the coronal images, the sagittal images shows the disc, and the open mouth images, it shows the normal disc mobility. The still images are better. So what you can observe is that the posterior band is, the part of the posterior band is extending beyond or posterior to the mandibular condyle. That is how it is positioned, centered on the coronal images, and it gets reduced with the intermediate zone position between the mandibular condyle and articular eminence on open mouth images. So this was posterior displacement with reduction. Coming to the left TM joint of the same patient, so that was the disc. This is the closed mouth images, again the similar appearance, and the open mouth images wherein it gets reduced. So the still images where you can see the part of the posterior band, it is projecting posteriorly beyond the mandibular condyle. That is how it is centered on the coronal images, and the open mouth images showing its normal mobility and position properly between the articular eminence and condyle. So again, this is posterior disc displacement with reduction. This was a case of bilateral posterior disc displacement with reduction, which is quite rare, and it usually clinical complaints is of an episode of jaw locking in open mouth position. So how do we identify? If low signal tissue is seen posterior to the superior prominence of the condyle on sagittal images, this should be interpreted as posterior disc displacement. It has to be differentiated from the fibrosis or remodeling of the retrodiscal structures that occur with anterior disc displacement, as in this case. So that is the disc. This are the retrodiscal structures, but the fibrotic changes never extend posterior to the mandibular condyle. So that is how you can differentiate. Now there are three categories of posterior disc displacement. There is thin flat disc, grossly posteriorly displaced disc as in our case, or it may be a perforated disc with a part of the disc displaced posteriorly. The distinction from a normal disc position is the signal characteristics of the posterior disc attachment, because we know that normal posterior disc attachment, the bilaminar zone, it can be high signal or intermediate signal, whereas if you see low signal intensity structure like that of the disc extending posteriorly, then it is posterior disc displacement. Coming to case 5, 28-year-old male complaining of decreased mouth opening and intermittent pain in left TM joints in 6 months. So if you can see these closed mouth images, anteriorly displaced crumpled disc on the open mouth images, the disc remains anteriorly displaced and does not reduce. What is worthy of note is that there is an shape abnormality of the condyle. There is a large defect or an excavated shape of the mandibular condyle, and which you can appreciate on the CT much easily. So that is a shape abnormality of the condyle associated with TM joint dysfunction and abnormal disc position and mobility. A 40-year-old female with pain in left TM joint, occasionally since 6 months. So if you have a look at the coronal images, you can see that the shape of the condyle was abnormal. On these sagittal images, though the triangular disc has maintained its morphology and is in normal position, and on open mouth, the intermediate zone remains positioned between the articular eminence and mandibular condyle, that is normal. So basically, this is bifid shape of the condyle and otherwise normal disc mobility. Whereas the contralateral side had normal appearance. we'll skip the normal appearance. So basically, it was a right TM joint which was having a normal appearance, and the left TM joint which was a bifid condyle, and there was little thickening in this region of the disc. Otherwise, the bow tie morphology was maintained, and there was normal disc position and normal disc mobility. So there can be varying condylar shapes. This is the normal shape of the condyle. It can be bifid like we saw. It can be flattened. There can be an excavated condyle, the same example that we saw. It can have a pointed appearance, and it has to be differentiated from the pathologic appearances like erosion of the condyle as is seen in rheumatoid arthritis, or the secondary arthrotic changes where there is reduction in joint space with sclerosis, subchondral cysts, marginal osteophytes. Besides that, there is one developmental defect in the tympanic plate known as the foramen of Huschke, which presents as a 3 to 4 millimeter defect in the entero-inferior part of the external auditory canal and posteromedial to the TM joint. This defect has to be identified. It's an anatomic variant, and it may present as a polyp in the external auditory canal, or it may cause salivation otorrhea, or the TM joint tissue, it may herniate into the external auditory canal on mastication, or when the TM joint arthroscopy is done, then you may inadvertently enter into the external auditory canal, or whenever there is infection or tumor or any disease, pathologic disease process involving the TM joint, it can extend into the external auditory canal if there is a presence of this defect known as the foramen of Huschke. So you need to comment if there is a defect like this, which is an anatomic variant. Coming to last, the joint status, we have to comment on the changes of arthritis if present along with TM joint dysfunction. This particular case is a case of rheumatoid arthritis, whereas there is joint space reduction with erosion. There is fibrous ankylosis of both TM joints, the right worse than left. Along with that, there were changes in the atlantoaxial joint. Unfortunately, I don't have MR images of this. Since there was fibrous ankylosis, we've done a CT scan of this patient. So as a recap, to summarize, we evaluate closed mouth images for disc morphology, whether it's crumpled, irregular, the signal changes, like whether there's disc thinning, crumpled appearance. We evaluate the position. Medial versus lateral is decided on coronal, whereas the anterior versus posterior is decided on sagittal images, oblique sagittal images. This displacement is evaluated on open mouth images, where the disc, whether it reduces or it is without reduction or the stuck disc. Associated features like the mandibular condyle shape, the osteoarthritic changes, and joint effusion or synovitis, if present, need to be commented upon. Lastly, the reporting, how we evaluate the same manner, we have to put it in our reports as the shape, position, displacement, disc mobility, condylar shape, and joint status. So this is how we report. We have a tabular reporting format for TM joints, making it easy for the clinician to understand. There is a pictorial representation of the disc status that we give. And besides that, diagnostic images at glance of closed and open mouth images are provided so as for easy understanding. These are the references that were good, and you can have a look at these. Thank you very much. You can contact me further or for any queries on my email address. Thank you.
Thank you, Dr. Patel, for very informative lectures today. Let me remind all participants, if you wish to ask question, just type your question in the chat box. Mention the presenter you want to ask to, and the presenter will be answered your question also in the chat box. Our third speaker for plenary is Dr. Sikandar Sheikh. He served as a consultant radiologist at Department of PET-CT and Nuclear Medicine in Yasoda Hospital, Somajiguda, Hyderabad, India. Dr. Sheikh will deliver a lecture about molecular imaging in musculoskeletal pathologies. Dr. Sheikh, the time is yours.
Hello, everyone. It's a pleasure to be part of this annual meeting of Asian Society of Musculoskeletal Radiology. as we have seen, there are a lot of advances which has happened in musculoskeletal radiology. So one of the important thing is the imaging aspect, which has gone to a molecular level. So I will be speaking on the topic of molecular imaging in musculoskeletal. So we all know, just a brief overview of our presentation before starting to the molecular aspects, because these are certain things which we should remember and try to analyze it in relation with the molecular imaging. So we all know what exactly is a molecular imaging component and how the musculoskeletal system, different cells, different tissues are related with that. So MSK is a specialized tissues. They are comprised of bone, teeth, cartilage, tendon, ligament, and skeletal muscle. And the cells of mesenchymal origin, because this is very important. You have osteoblasts, odontoblasts, chondrocytes, tenocytes, ligament cells, skeletal myocytes, musculoskeletal mesenchymal cell types, of pathologies involved in musculoskeletal system. So you have trauma, arthritis, degenerative, malignancies, infection, inflammation, benign pathologies, miscellaneous conditions. And the clinical aspects are the most and foremost symptom is the musculoskeletal pain. So that is how the presentation of the clinical aspects are starting. And patient presents with this commonest presentation. And to distinguish between acute or chronic changes, so we have to evaluate whether these are acute changes, chronic changes, various arthritis and their stages, early articular cartilage changes, or erosion, destruction, or any sort of hyperemia. Then distinguish tumor recurrence versus post-operative changes. This is very coming to technical aims. You can identify, diagnose non-invasively. Specific abnormal cells can be evaluated at a molecular level and also can study the normal physiological events. So we are dealing with cellular metabolism, stress, and apoptosis, which can be followed. Then you have disease-specific molecules which can be targeted, and particular gene-related events can be assayed in living subjects. So advances in imaging technology, engineering, chemistry, molecular biology, genetics. So this all combination will lead to a multidisciplinary and multimodality effort leading to the molecular imaging. So you have molecular imaging. What exactly it is? It is defined as non-destructive in vivo visualization and measurement of the biology at the molecular and cellular level. So it is non-invasive imaging of biological processes, mostly used at present in a preclinical research, and then probably down the line in coming years, it will be more commonly and precisely used for the clinical evaluation. So the use in endogenous bone cell biology, assessing cellular responses to exogenous biomaterials. So what are the applications of molecular imaging in MSK? We have seen in relation with the cells, so we can identify, track, trace, evaluate, and then give information of the osteoblast, osteoclast, and hormones, which are the bone-related, bone-forming, bone destruction cells. Then you have pathological cartilage and bone destruction. So usually the bone and cartilage, they go hand in hand, especially in relation with the joints. So one pathology involves another pathology concurrently at some point of the time during the disease process. You have skeletal gene and cell therapy with and without biomaterial support. Then you have cellular process in osteolysis and osteomyelitis. So research bone fracture and arthritis to skeletal cancer. So advances are heralding great potential for innovative clinical imaging in orthopedics, rheumatology, and oncology. So what are molecular imaging? What it is? So the existing, the most common, the most widely used is ultrasound. But very few of us know that ultrasound is one of the safest and the best bet of molecular imaging component in future. So a lot of applications, a lot of newer trends, new radio tracers, new contrast, they are coming in relation with the ultrasound. So this will be one of the most fascinating aspect, and the most important is the non-radiating modality. So same applies to MRI, again non-radiation, but the evolution of MRI has grown from a very basic 0.3 or 5 Tesla to till now we are having 7 Tesla in clinical applications, and a lot of animal imaging and preclinical imaging is happening at 12 and 14 Tesla respectively. So along with this, there are a lot of functional aspects, technical upgradations in various aspects of the MR sequences is leading and will be the futuristic modality of molecular imaging. We have seen the ultrasound. So it is used as an imaging and therapeutic tool, which we know that we do a lot of biopsies, we do a lot of intervention procedures along with the diagnosis. So in relation with the gene therapy, so probably it has a varied role. Another aspect is ultrasound biomicroscopy has been used for in utero imaging and can guide injection of the viruses and cells. So ultra high frequency ultrasound can be used to determine cell mechanical properties. So you have imaging angiogenesis. Angiogenesis is a varied part in various pathologies, most commonly seen in the malignant neoplastic etiology, but still in infection, inflammation. We have seen the process of inflammation where the angiogenesis plays a very crucial role. So you have a microvessel density count where the cancers can diagnosed improved by the abnormal enhancement seen in a reperfusion kinetic method. So kinetic graph or kinetic representation of the uptake or the enhancement of the angiogenesis gives a very clue whether it is a high malignant potential lesion or it is a simple low-grade neoplasm or it is a infective inflammatory pathology. So based on this kinetic perfusion method, you can most of the times you can be easily identifying the process of angiogenesis and the pathology related to that. So coming to ultrasound, we know that microbubbles are the one of the ultrasound contrast agents, and their target is reticular endothelial cells, which is predominantly seen in the bone marrow. Then you have lymphatic system, inflammation, tumors, liposomal agents, microbubbles that so you have muscle, you have bone, you have tendon, you have regeneration. So depending on the microperfusion of the corresponding tissue, which can be quantified with contrast enhanced ultrasound using sulfur hexafluoride contrast agent. So contrary to MRI, CT, and X-ray examinations, the cost-effective contrast enhanced ultrasound is to be seen, and they are very safe. Renal impairment is very less. Ionizing radiation or use of contrast agents in the body, these are certain things which we have to take care, and along with the claustrophobia if you are doing MRI. So this plays versus the ultrasound. So ultrasound is very easy, very cost effective, easily available. Only the technique and the technical aspects of that molecular imaging software has to be there. Otherwise, it is very cost effective. You can use it very commonly. Now, coming to MR molecular imaging. So, we have seen a lot of aspects related with T1 weighted, fat suppressed, stir, chemical shift, diffusion weighted with ADC mapping, proton MR spectroscopy, unenhanced three-dimensional fat suppression T1 weighted, with reconstruction into other planes, time resolved MR perfusion, then delayed contrast agent, enhanced 3D fat suppressing T1 weighted, then you have subtraction images. So if you see this sequences, diffusion with ADC mapping is one of the important utility for the functional where the molecular imaging comes. Then MR spectroscopy reveals the metabolic basis, but still it depicts the amount of the cells, the pathogenesis or physiological aspects related to the particular tissue or a cell. Then we have time resolved perfusion. So perfusion is something what we have seen just before. Angiogenesis is one of the important components. So these are the things which can be used along with the various anatomical aspects. So MR gives a blend of anatomy as well as functional components with various technical parameters which are seen and being commonly used in various high-end centers or academic centers. So one of the thing is you have application and a technique. So this application and technique is something related with the detection, anatomy, then characterization, then you have anatomy, functional, metabolic, spectroscopy, determination of the extent, anatomy after neoadjuvant therapy. Then you have functional aspects. So if you see, first is for the detection, you have anatomy mostly. Characterization, you have anatomy as well as functional, then metabolic. We already seen functional, you have dynamic contrast, you have DWI. So dynamic contrast is one of the important thing because you have a kinetic representation in the form of a graph. So you can easily, so this is more commonly related with the tumors. Now you have imaging rheumatoid arthritis. So for example, this is something which has been fascinating, and I'm just showing you, if you see this entire blend of the uh, components which are being used, different techniques. You have T cell infiltration, you have antibody based imaging, macrophage recruitment, leukocyte recruitment, cytokine matrix degradation, synovitis. joint effusion, and soft tissue swelling. And the different temporal patterns, you are seeing hyperacute to acute. So sometimes the acute itself is very difficult to evaluate, and forget about getting the knowledge about hyperacute. So hyperacute is something where you need to easily identify, and that is where you can diagnose the pathologies before they are being very diffusely involved a particular area or particular tissue. So nuclear medicine, optical imaging, and MR plays very important role. Again, antibody-based imaging, you have nuclear medicine, various radio tracers, indium, technetium, then anti-E selecting fab. You have optical imaging parameters also. So if you see this, there most of them are available right now in clinical, and a couple of them are still in preclinical stages. So probably preclinical will be converted into clinical down the line in coming years. So you have macrophage recruitment, leukocytes, cytokine production, synovitis, joint effusion, and soft tissue swelling. So again, pattern is hyperacute to chronic, then acute to chronic. So most of the stuff here, what is the evaluation is based on the hyperacute to acute or acute to chronic. So these are the different aspects which you are able to see. And the role of ultrasound is mostly seen in the synovitis, joint effusion, then soft tissue swelling. So with the advent of technology and the upgradation of the softwares, ultrasound MR plays very, very crucial role in coming future as compared to other imaging modalities where a lot of radiation is involved. If you are using the PET or nuclear medicine, radio tracers, and various aspects. So these are all the things which has been seen. And if you see this down related, everything is available clinical. So with this graphical representation, if you see the majority, more than 50% of the applications are available in a clinical phase, and the rest of the things are not available. MR imaging, gadolinium, osseous, you again come back to the intermediate to chronic, because the acute stages are very difficult if you see by CT and MR for anatomical imaging, then tendon subluxations, dislocations, secondary osteoarthritis. So these are mostly related with our existing imaging modalities which are available. So molecular imaging in MR, we have seen the MR spectroscopy, hyperpolarized MR imaging. So optical imaging, you have bioluminescence imaging and fluorescence reflectance imaging. You have optical imaging, absorption and scatter of incident photons by biologic materials are used. Then you have fluorescence-based optical techniques, sufficient tissue penetration, image superficial regions like joints, and you have microbubble contrast agents in ultrasound, which are much useful. So imaging of osteoblasts, osteoclast, and hormones. If you see the osteoblastic activity, so in vivo imaging, it is a bone forming osteoblast. So blasts are bone forming. Then from the osteoblast specific osteocalcin promoter, they monitor non-invasively in the bone tissue. So by the various techniques of light emission, correlated activity of osteoblasts in hypertrophic chondrocytes like vertebra, calvaria, carpals, tarsals, and spine. Then you have developmental expression, osteocalcin in this tissue, bioluminescence imaging, and in vivo time course and peak of osteocalcin expression, post-damage skeletal gene, and cell therapy. So there are a couple of things. For example, you are having a reporter genes, you have probes, you have antibodies, you have particles. So particles are MR based, and then antibodies, you have fluorescence, nuclear. Probes, you are having activable and static. Static again have fluorescence and nuclear. Activable are fluorescence. For example, you have enzymatic cleavage here. Reporter genes, you have promoter and reporter genes. So reporters are bioluminescence, fluorescence, and nuclear principle. They are based on various technical aspects which are related with this. So if you see this blend, this is imaging visualability based on the different components which are being used by the different imaging modalities like MR, nuclear, fluorescence, then you have bioluminescence, and you have cellular accumulation and radiolabel substrate traces. So bioluminescence imaging, we all know they detect osteocalcin activity in the bone, active bone remodeling, including various bones, teeth, paws, and vertebra, then imaging. They are already well-established imaging modalities. Now, we all know imaging of the fluorine. Fluorine is an important component of the bone, and you know that fluoride scan or 18 fluoride PET is being widely used. So it is a radio-labeled methyl diphosphate imaging tracers, biphosphonates. They can inhibit bone resorption. So other applications are infection, arthroplasty, metabolic bone marrow, back pain, non-malignant bone marrow, arthritis, non-malignant benign conditions, graft evaluation, healing fractures, osteonecrosis. So we all know the pathology. I'm not going in detail about this. So there are a couple of cases which I will be showing on the PET. So you have 18 years old female diagnosed primary, then having sarcoma for whole body staging. So this is a local disease with the erosion, destruction, infiltration of all the muscles here with the deformity and the changes involving the joint, but rest of the body is absolutely normal. This is normal urinary bladder, normal pelvic system, normal oropharyngeal tonsils, and this is a normal cerebral uptake. But here it is a significant uptake with necrotic areas. So it is a locally infiltrative lesion which is involving the left proximal thigh. This is osteochondroma, benign, absolutely no uptake is seen. This is a lesion which is seen involving the bone on the left side here. So this is the left tibia here, which is seen lobulated in the uptake, and focal area of uptake is also seen in the proximal marrow. So rest of both lower limbs is normal. So it is just traumatic, non-healing, soft tissue swelling with discharge and inflammatory changes. So coming to another, this is a diabetic foot which shows a diffuse circumferential soft tissue, irregular infiltration seen, edema is seen corresponding with the diffuse amount of uptake. So in a later stages, probably the bones will also get eroded, destroyed with synovial thickening and all that aspects. So prosthesis imaging is very important. This post prosthesis is uptake seen here in the PET, and PET is one of the most important modality as compared to the other imaging modalities which is seen here. So this corresponds with the rest of the body. So here transplant rejection or aseptic loosening can also be seen in the post-operative. So this is very crucial for the involvement. So facet joint hypertrophy, simple back pain, arthrosis, sclerosis with hypertrophy. So this shows diffuse uptake, so not to be mistaken for any tumor or something like that. Obese patient, knee joint, see amount of uptake is seen non-obese. So more the amount of weight bearing, wear and tear involving articular, subarticular regions. So this is very crucial. That is how the uptake and molecular imaging aspects can be seen. This is classical rheumatoid arthritis. Normal hand, absolutely no uptake. Rheumatoid, significant soft tissue swelling, synovial thickening, synovial edema, with periarticular involvement showing significant amount of uptake corresponding with the arthritis. Myofibrosis, this is one of the image. This from the reference which I have taken from the PET clinics, which shows diffuse increase, significant uptake involving the entire bone as well as the bone marrow. An osteoporotic collapse, there is acute, so there is a reactive changes, so which shows significant amount of uptake. This has to be differentiated from the tumor or malignancy. Diffuse marrow uptake, post chemotherapy, post reactive changes is also relevant and it has to be monitored. So you should not diffuse, think of any sort of diffuse metastasis, but two can occur if there is any metabolic changes in the body. So sodium fluoride is there. So this is sodium fluoride with multiple skeletal metastases, more sensitive for the sclerotic lesions as compared to the lytic lesions. So, and sclerotic lesions with FDG cannot be identified, but in F18 scan is very high and more sensitive. So another radiotracer for the bone, we have seen Dotonok for the prostate, which has seen the local disease and the involvement and metastasis, erosion, destruction with the associated soft tissue component, right lower femur with infiltration into the soft tissues. So that is how the use of other radiotracers are also seen. You have leukocyte scan, you have citrate, then these are all being used. And if you see this, these are the various radiotracers used in musculoskeletal system, FDG, sodium fluoride. So this is a lesion which is locally infiltrative lesion which is involving the pelvic mass, right sciatic notch with perilesional edema, and there is significant involvement of the soft tissues here. So sensitivity wise, soft tissue is very, very crucial. So this is sodium fluoride PET fusion imaging with the post-traumatic arthritis. So you can see the amount of the changes which are able to see in the subarticular regions of the joint. So which is very, very important. So this is one of the last image which I'm showing. So you have axial and coronal, you have again the rheumatoid arthritis with the PET MR. So MR, soft tissue, synovial thickening, skin, then soft tissue, muscle involvement, vessel involvement, neurovascular bundle involvement. Definitely this is very, very important. So I would like to finish this. This is also again in suspected spondylodiscitis, which is seen here, changes in the CT, MR, and PET, and this is a conventional radiograph which shows not much. So imaging pain, very important. Pain is the most common symptom. You have to identify the cause of pain. So that is where the earliest form of functional or molecular imaging comes, where to evaluate physiology, molecular and cellular changes. and also in a chronic pain evaluation. So this is something like a physiological and pathological, that is where you can metabolic response, hemodynamic response, mediator response, cellular response, and what are all the imaging modalities which can be used. So still the PET and FDG is very, very important. So imaging biomarkers are for proliferation, metabolism, angiogenesis, apoptosis, interactions, prediction, prognosis, and response assessment. So these are all combination now. This is not only a purview of imaging. We have molecular biologists, rheumatologists, orthopedic surgeons, engineers for techniques and the technical aspect, chemists for the chemical aspects, physicists for again protocol setting techniques and all that, then pharmacologists, then next generation of molecular imaging technologies will be for diagnosis and treatment precisely for the musculoskeletal system. So thank you all for your kind attention, and thank you.
Thank you, Dr. Say, for giving us an interesting lecture. Our last speaker for the plenary session is Dr. Chen Xiaohuang, the Director of Radiology Department from Beijing Jishuitan Hospital. Dr. Cheng will give a lecture about the application of double-layer detector spectral CT in musculoskeletal. Dr. Cheng, the time is yours.
Good morning, ladies and gentlemen. It is really my pleasure to be here, present to you a talk on the application of dual-layer detect spectral CT in MSK. Before I start my talk, I would like to thanks to the Professor Paulus, who organized this year AMS meeting in Indonesia. And I thank him for his hard work to make this year as an AMS meeting possible. Today, I would like to share with you our initial experience with the spectral CT in MSK. I'm working in Beijing Jishuitan Hospital, which is an old orthopedic hospital in Beijing, China. Now we have 3 campuses, which is the largest orthopedic hospital in China, and we are every year we are taking care of a lot of orthopedic patients. I'm going to talk on the spectral CT in the 4 content. First, the principle of spectral CT actually use different energy X-ray, so you will get different attenuation. Use of a different energy X-ray scan can separate different tissue, and this is not that new. For example, the bone densitometry machine, the DXM machine, actually use this dual energy mechanism. So, for example, we have the tissue of bone and the soft tissue and the fat. And as you can see, at the low energy, they are separated well. And in the high energy, they are not that well separate. So if we can scan the tissue with different energies, and then you get a different attenuation. And this is the principle using for DXM machine. And as you can see, this machine was developed in 1987 and widely used in osteoporosis area. Also, the dual energy X-ray was tried in the CT area. As you can see, this publication, which is very early in the 1987. And as you can see, use the CT scan, and they are scanned sample with 2 kV, one is 8 kVp, and another is 140 kVp. So scan twice, and then looking this correlation between the QCT BMD measurement with the bone edge. And as you can see, this is quite high correlation. And of course, if you use dual energy, you get even high or more accurate measurement. but of course you need to scan 2 times and you get 2 times of the radiation. And as you can see, if we can look at the PubMed and looking for spectroscopy, and you will see it is started very early, but it increased dramatically in the time of 2010 sometimes. Since during that time, we have the new CT, which we call the spectroscopy, come into marketing. And there you will see a lot of research and clinical application searched from that time. Now we have a different manufacturer and they use a different technology to achieve the spectroscopy. For example, for Siemens, it uses 2 tubes, use 2 kVp. And GE, they use the rapid switch energy. And typical Philips, they use dual layer detectors. And of course, they use different technology and mechanism to get 2 or different energy of X-ray. And as you can see, Philips, Siemens, and GE all have their products in the use, and it has advantage and disadvantage. And there's a nice paper published in Diagnosis Innovation Radiology 2020, and this is really a nice review on this topic. So if you are interested in that, definitely I recommend you to go to read this paper. Really, there's a lot of information, very helpful. The function of SCT, we acquired a Philips Icon CT in last year. It was installed in our new campus. And after 1 year, we complete 30,000 exams. And as you can see, a lot of bone tumors here. And this is our new campus. And this is the Philips Icon CT scanner. And as you can see with this special design, and it has one tube, but it has 2 layers of detectors, and 1 layer to receive the high energy photon, and then another to receive the high energy. So it uses the dual layer detectors. So the X-ray was synchronized in the time and the course and the direction. So this is the scanner. Look nicely. As you can see, this is an X-ray beam, and it come here and received by the top layer of detect. And then you have the bottom line. And in the side, you have this data, which is come out here. So as you can see, if you use 2 layers of detectors, so you have the raw data for the high energy and the raw data for the lower energy. And of course, it will first will come up with the regular CT scan image. Of course, this raw data can be further reconstructed, demanding into the spectral-based image, and can do the spectral analysis. With this design, every CT scan can be the spectral CT. So you simply just click on this SBI. So there's no need to preset or pre-selection. So every CT scan can be the SCT. It will come up with the spectral basic image, what they're called SBI. And this is a set of images which contain 12 set of images, and now they have more. SBI can be viewed in the console or the PACS system. So this is the conventional CT scan and this detector. And this is the Philips dual layer detect CT scanner. As you can see, you have 2 layers of detector, and they put this data collection system in the side. And this is typically after you finish one scan, and it will come up with a conventional image. Of course, this is the contrast one. And then you have this 40 keV virtual monoanogenic image, which is the increase the contrast for soft tissue. And this is a high energy image. And then you have an iodine map, virtually non-contrast, and this fusion images, which looks very impressive. And of course, with the SBI, you have all these images available. So you have a conventional image, virtual model image, and you have a high and low, right? And you have this iodine density image, which show you the concentration of iodine into the tissue. And this is the effective image, and this virtual non-contrast image. And of course, they have different applications. And then you can see here we have the contrast enhanced image and uric acid image. And then you have the technique to suppress the signal of the calcium, make the calcium black, and what we call the calcium suppress image. And then you have the electron density image, of course. And then it all have their advantage and has different applications. Actually, we are used this CT scanner for more than 1 year, and we are using this typically for the CT scan of bone tumor and other disease. And of course, most of the time we use this just as a very nice CT scanner. And of course, it has the spectral CT capacity, and then we can we can try different things on this new machine. For example, it is widely used or widely studied. So, for example, we have a CT scan of the spine, and you will see there is a fracture. The question is the fracture is new or it is an old one? And then the clinician wanted to see if there's any edema inside. And of course, you can easily to get the MRI done. And this is a T1 image, sagittal, and this is still image, and they clearly show you the edema here in the up part of the vertebrae. But with the SCT, and you can use the calcium suppression technology, and it will suppress the calcium signal, and it will show you up this edema. And if you compare with the MRI, and it looks quite similar. And you can see a lot of publication and then look at this particular issue. This is another case, show you it is an old fracture of the wrist. And of course, you have fracture of the distal radial and the distal ulnar. And again, you can use this calcium suppress technology to show you the bone edema around the fracture line. And this is the MRI image with the fat suppress. And as you can see, this is well matched with this calcium suppress image. This is a lymphoma patient, and we use the CT scan. And the up row show you the conventional image at different place. And the second row is the calcium suppress image. And then you can combine them, fuse the image, and it will show you the foresight, this change in this bone marrow, which is not clearly seen on the regular image. And when you compare with the PET image, and as you can see for this particular case, it is well correlated with the PET CT findings. And this is a case from Regional Hospital of Shanghai. Also, we can show you here, this is the bone metastasis. And as you can see, this is the CT image of the pelvic. And here you see a different place. You have this bone destruction. And for this case, this is a male. And they have the prostate image within the image. And as you can see, this bone destruction area of the scapula, and you will see this curve or this characteristic of the attenuation with the different energy, which is very close to the area of the prostatus. So with this, we can show you this metastasis is come from this prostatus. So this is one of the function you can try when you have the see the disease in the bone and try to correlate with the original place. And of course, with the SCT, it is possible to quantify this uric acid. And as you can see for this case, after the CT scan after both feet, and the uric acid was show you on the color, and of course it can calculate the volume of this uric acid. Here again is another case, show you with SCT, you can see this bone destruction. For example, for this case, we see here in the rib, there's a destruction of the bone. Also, inside of the vertebrae, we see another place, you have the destruction of the bone as well. And with these mono images, and with the Z effective map and IDAM map, and we can tell you. And for example, here you have this rib here, the density, and then you enlargement of the rib, and here you have this destruction, and also here, and it will show you this is not a metastasis, this is a metastasis, and this is a normal, or is a normal variance, and here is metastasis. So with this function, we can looking for different these bone layers, and then we can differentiate them. But of course, we can also look in this regular image, and you have some idea. But with the SCT, you have more opportunities or more functions to compare them. And of course, there's another application for SCT is for the metal artifact reduction. For example, this is a case with both side total hip replacement, and this is original one. You see this very obvious this artifact of the mat, and this is use this MIR, this software to reduce the artifact. And if we use this model imaging, this high energy plus MIR software, and you will perfectly reduce this metal fat. Here, as you see, this is quite complex cage, and we use the SCT plus MI, this software. And as you can see, this is the low energy, this is the high energy, and this is original one. And as you can appreciate clearly with this SCT, we are able to reduce the metal fat substantially and show you nicely this fracture and healing process. The future direction of SCT, this is something quite difficult because we are just at the beginning. So I was thinking SCT is one of the future direction of CT development. So I think everybody should think about and know about this. Second, I think we are not fully understanding the principle of SCT. So we should study more and learn more to know more about the principle of FCT, and then you can have more idea or think about more clinical applications. And of course, we need to lower the radiation dose. as you can see, there are different companies. They are produce different kind of SCT. And here I show you is the one manufactured by the Philips. And of course, we have GE and the Siemens. They have different kind of SCT. And some of the SCT, actually, the radiation is quite high. So we need to lower or reduce the radiation dose. And as you can see, even after 1 year of use, to be frankly, it is a very initial experience. So far, we don't think there's much scenario use CT, the problem can be solved. So this is something we need to think about. So for the SCT, it is a new direction, new product, and we should think about how to use them effectively. At this point, I think for me, it is just a beginning, and we don't have much experience. But again, I thank Professor Paulus to give me this opportunity to present you the very initial experience of our use of SCT. And I have been in Indonesia several times, and it was very impressive for the people and for this professional achievement you have made. I hope in the future we have a chance to come to visit your country again. And it is my talk, and I will be happy to take your questions. Thank you very much.
Thank you, Dr. Cheng, for your informative lecture. Again, for all participants who wish to ask questions to the presenter, please directly type your question in the chat box. Any unanswered questions will be replied directly through email. Please mention the presenter you wish to ask. Dear colleagues, Dr. Cheng's lecture is a wrap-up lecture for the plenary session. And now, our supporting partners will give their presentation. Please welcome the representative from USGH, Ms. Revina, and Mr. Gatot from GE Healthcare. First presentation will be conducted by Ms. Revina. Ms. Revina, the time is yours.
Thank you, Dr. Shiani. My name is Revina. I'm applicant specialist from USGH. It's a distributor for Samsung Medicine. First of all, before I begin my presentation, I will show you a video about MSK image gallery from Samsung Ultrasound. This is our image for Samsung Ultrasound. It's a patellar tendon with our feature panoramics, and next is a shoulder with S-harmonic. It's superficial flexor declutorium with XQ vision. And next is supinatus tendon with SC wave imaging. It's worse from with HQ vision. And next we have bicep tendons with clear vision. Elbow with SQ vision. It's a finger flexor with a S flow. It's a flexor plastic long tendon with clear vision. Finger with MV flow. It's quadricep tendon with SQ vision. Knee with panoramics. Nerve track is an application to detect nerve automatically. Now, I will show you my presentation. So this is all few products that list on the AK catalog. We have a portable ultrasound. It's SM70. Sorry. This is our few products in a catalog. First, we have SM70, and next we have 8H30, and then we have 8H50, and HS60, and WS18. Besides the ultrasound, we also have X-ray mobile digital system. It's GM3085, and retrofit system, it's GR40CV, and also we have a codonics disk publisher. So why MSK is important? Among all these diseases, between MSK, circulatory, respiratory, diabetes, and cancer, MSK has most percentage in adult as a chronic disease. It's 54%. So we have to put our effort more in MSK application. We have to have a better move, walk, and better run. And that is the solution for active and energetic life. So this is the area where MSK scanning is applied for. First, we apply it in orthopedic surgery, and anesthesia and pain medicine, and rheumatology, sport medicine, and also in rehabilitation. So to support all this application, we also have a great ultrasound spec to support the scanning. We have to clear muscular. Hello. So this is our application to get a clear MSK imaging for an accurate diagnosis. First, we have S-harmonic. Okay, I will show you. So we have first we have S-harmonic is a feature to provide image uniformity from near to far field, while reducing signal noise and improving image quality. And next, we have a panoramic. It's a feature to restructure a screen to the image processing to achieve a wide range of image. It helps understanding the anatomical connection with other program with another occurrence. The third feature that we have to improve image quality, we have HQ Vision. It's a feature to help user to get a high resolution image and detect clinically important details. Next, we have a feature to help guidance technology for optimal precision. First, it's a feature called Nerve Track. It detects and provides information of the location of nerve in real time during ultrasound scanning with the anesthesiologist and expert practitioners. So this feature can help user to find the nerve easily. It detects automatically, so it will reduce our time to scanning. And next, we have this feature. It's a needle meet. Needle meet helps user to ensure precise needle targeting while performing commonly used in interventional procedure. So it will enhance the guidance and guidance the needle through the interventional procedure. Next, we have a beam steer. It's a feature that provides the high level of efficiency and safety in needle placement with identifying the location of needles. So it also will help a user to get the target area more specifically and more accurately. And next, We have some feature to help user to identifying the Doppler image more clearly. First, it's a feature called MV flow. This feature provides a detailed view of blood flow in relation to surrounding tissue or pathology with enhanced spatial resolution. So MV flow is a abbreviation from microvascular flow. It helps to detect a very vascular that's very small and very tiny, and it gives more high resolution and more sensitive color Doppler. And next we have a LumiFlow. It's a feature that gives three-dimensional visualization of blood flow, and it can help to understand the structure of blood flow and small vessels intuitively. So this feature basically use the 2D mode, and then when doctor apply it, it will enhance the visualization of Doppler, and it will give a visualization for the vascular like a real 3D image. But basically it applied on 2D image. You can see the video here. It's beautifully colored the flow, applied it LumiFlow. So first, how to use SQ Visions. It's a simple application. We need to press the button on the touch screen, and SQ Vision has index from 1 until 3 to apply it in 2D image. You can see the difference here. This is SQ Vision off, and this is the SQ Vision on. And next we have panoramics, and it's also a simple way to activate it. The user just to click the panoramic on the touch screen, and you can see it gives the long scanning with one scan, and it's up to about 30 centimeters long. So next we have a nerve track. It's basically based on artificial intelligence, and it can detect the nerve automatically. The nerve that nerve track can detect is a median nerve, ulnar nerve, right interstellar brachial plexus, supraclavicular brachial plexus, and axillary brachial plexus, and it's scanned in real time. Oh. It's close. Well, next we have. Oh, okay. That's all about our presentation. I give it back to Dr. Siani. Thank you.
Thank you, Ms. Stefina, for your wonderful presentation. And next, let us welcome Mr. Gatot from GE Healthcare to conduct his presentation. Mr. Gatot, the time is yours.
So thank you, Dr. Siani. Good afternoon, ladies and gentlemen. Just want to check, Dr. Siani can see my screen and also can listen me and the good.
Perfect, Mr. Gatot. You can
Okay.
continue.
Okay, sure. Thank you very much. So Good afternoon, ladies and gentlemen. Uh, for the presidents of the and chairmen of the Indonesian Society of Musculoskeletal Imaging, all the board members, and all distinguished lecturers. So today we would like to update you what's happened in the industrial of MR with the latest of technology. So my name is Gatot Santosa, modality leaders from GE Healthcare for MR. Would like to talk in about next 10 to 15 minutes about the latest technology of GMR. So we don't want to talk about in detail starting from 1982, but we would like to discuss this afternoon starting from the 2019 to 2021. So which we are having the new technology with Ericon deep learning at 2019 with 2 dimensions, then continue with 2020 with osteobone cortical imaging. So we design new pulse sequence which MR can image the cortical bone. And the last one, we would like to introduce you with Ericon deep learning and 3D. So 3D Ericon deep learning now is not commercialized yet in Indonesia. We trying to selling out as soon as possible. So here just a few years back that we are first introduced with the Ericon multi-purpose coils. So now we are available at the large and medium size for the air coil technology. So if you can see in the screen, so we have now the smaller size of the Ericon deep learning, which is can applicable for shoulder, knee, elbow, foot, ankle. So this one will deliver you significant increase image quality and more comfortable to the patients. So if you are taking on detail, so the elements and channel of the coils is 21 elements and channel for large size and 20 channels, elements, and for the medium size. So then we go for the Ericon deep learning. So once the radiographers now lead the MR console, we are familiar with trade-off. What is the trade-off? When we want to have the higher image quality, then we need to take longer scanning time. And when we take longer scanning time, the patient is not uncomfortable. So that is the reasons of one of the reasons why the trade-off happens, because radiographers have to choose whether they want to go fast or go high resolutions. So now we deliver the Ericon deep learning, which is Ericon deep learning is not filtering image, which is Ericon deep learning not filtering raw data. So Ericon deep learning is new algorithm which is can define what is the true SNR, image artifact, and the noise. So this is the contributors from the Holly Spotter that they are saying that with deep learning, we can absolutely having delivered the fastest scanning time. If you want to see the higher image quality, then we can see here with the same image quality, with the better image quality, with the same scan time, we can deliver with Ericon deep learning. So if you want to go more deeper in the conventional image reconstructions vs deep learning, so before the observer can see the image on the image console on the workstations, there is a 2 times image data and also raw data filtering. But now we don't have no more using the raw data filters or image filters. Now we train the image reconstruction engine with the 200,000 cases to be independently can identify what is the true SNR, image artifact, and noise. So if you can see in the images, there is the knee scan with the GE protocols and scanner with the 384 times 256 matrix resolutions with 2 necks. There is a delivered 2 minute 47 seconds scan. With the deep learning, we can even deliver higher matrix image resolutions with a faster scanning time. So in overall summary, we can deliver the higher resolutions by 17% with scanning time reductions 41%. So here the example for the shoulder scan, when the initial protocols is metric resolutions with 352 by 224 with 1.5 nex with 2-minute 58 millisecond scan. With the new deep learnings, we can increasing the metric resolutions plus faster scanning time. So in overall, for the shoulder image, we can deliver 50% image resolutions increase with the 26% scanning time reductions. So this is for the examples. This is using the dedicated shoulder knee 16 channels with the conventional image 0.4, 0.6, 3.0 mm with a 2-minute 58-second scan. With the Aricon deep learning, we can even smaller slices with 2.3, 0.3, 0.5, and 3 mm with 2-minute 11 seconds. So in overall, for this example of using the dedicated shoulder with coil deep learning, so we can demonstrating 26% improvement in scanning time with 50% improvement in resolutions. So here the example using the dedicated knee, 18 channels dedicated knee. So if you can see here, we can deliver the faster T2 fat sets with 0.4, 0.6, and 3.5 mm. So talking about the spine imaging, we can even having the 14% reduction in scanning time with 52% spatial resolutions improvement and 70% increasing of the SNR. So for whole fast spine exam in total 5 minutes with Aricon deep learning, we can deliver 6 image with So Dr. Shani, can you hear me?
Yes.
So still you can see my screen?
Yes.
Okay, let me just continue because now just a technical challenge. So so now we would like to introduce the new MR sequence for bone imaging. The reasons why, because the deposit of proton hydrogen in the bone is very less. So that's why MR have a challenge to image the bone. But now we have a new pulse sequence. The sequence called is osteo. TEO for bone imaging. What is that? So that is based on the radial equation of zero time echo. So ZTE is stand for zero time echo, which 3D gradient fast SPGR. What is the benefit? Benefit is we can have the cortical bone surface imaging as a complement for the MR soft tissue exams. So let's go in the clinical setting. Here the example from our contributors from the Middle East. So the patient history is 32 years old male diagnosed with osteomyelitis lesions on CT. Then patients come to the facility following up with the MR and ZTE MR sequence. So this is for the conventional sequence. We can see the coronal PD fat set, T1 fast pinico, and the rest of imaging using the conventional sequence. When we go for the reformed image, then we can see the ZTE MRA formats, if you want to compare with CT, then you can see that we can deliver the equal or as a complement for the CT image to evaluate the osteomyel in the bones. So this is the comparison between MR reformat versus the sagittal reformat of CT, while the MR have benefit to image the bone without the radiations. So the conclusions of this sample of the ZTE is the pathology report with MR also as a osteomyelite and schedule for the next exam with the MR. So with the new technology for the osteoband MR volume rendering, so we can also render the image as the previous render approach from the CT. And also this one of the example and the shoulder for the cortical bone imaging with the new pulse sequence. So this is also the contributors start talking in the clinical way, in the scientific way. They start to write in the paper of the journal or in the research for the utilize of the ZTE MR for bone imaging as a complement for the existing technique for image the bone. That is from last slide from my presentations. Dr. Sieni, time's yours. Thank you.
Thank you, Mr. Gatot. Very interesting presentation. All participants, you can visit our partners booth at Expo Hall and get in contact with them for further inquiries. We have many partners participate in this event, and you can see the advance of imaging technologies from our partners on their exhibitions. The plenary session is now completed. Participants could enter Hall A or Hall B to join the parallel meetings. Hall A will conduct general topic of inflammatory joint diseases, and Hall B with general topic of non-inflammatory joint pathologies. Dr. Tarika Salamah will act as the host in Hall A, and I will be the host in Hall B. See you in parallel session starting from 11:30 West Indonesian or Bangkok time. Thank you.
Okay, good morning, everyone. Welcome to our first breakout session of this meeting, which will be about inflammatory joint diseases. First, we will welcome our first speaker, Professor Vijender Arora from Department of Radiology, Sri Guru Ramdas Institute of Medical Sciences and Research, Amritsar, India. She is the professor and also former head of radiodiagnosis of SJRDH Amritsar. Professor Vijender Arora, time is yours.
Good morning, everyone. It is indeed a privilege and a pleasure to be talking here today. And I would like to thank the organizers for giving me the opportunity to do the same. My topic of discussion is radiopalmistry, reading the hand radiograph in systemic disease. I would like to dedicate this talk to the late Dr. Kakarala Subbarao, who's the father of musculoskeletal radiology in India, and who has contributed many of the radiographs that I'm going to use in this presentation during his lifetime. I would also like to acknowledge some of my other colleagues who have contributed some of the radiographs that I'm going to use in this presentation. There is a host of conditions which can manifest in the hand radiograph, including autoimmune and inflammatory disorders, endocrinal and metabolic or nutritional pathologies, infective pathologies, and some miscellaneous conditions. I'm not going to talk about congenital or developmental anomalies in this talk because that would merit a separate talk in itself. This list notwithstanding, I'm not going to base my talk in this order. I would rather discuss the various findings that we find on the hand radiograph and then take you through the differential diagnosis one by one. So the first condition that I'm going to talk about is acroosteolysis, which means which is the resorption of the distal phalanx. And there is a certain approach that you should follow in reading any type of radiograph, whether it be hand radiograph or let's say a pelvis or an extremity or a skull. We either go from outer to inner or inner to outer and superior to inferior or lateral towards the center. So in this, I'm going to start from distal towards the proximal, and that's why I'm going to start with acroosteolysis. Just to show you the first case, in this, this is the early and this is the late stage of the condition. And in the early stage that you can see, now if you look at the tuft, this is a normal tuft of the distal phalanx, right? And you can see that there is a blunting of the tuft out here. Besides that, you can see the soft tissue calcifications. You can see multiple areas of soft tissue calcifications here. And if you notice quite closely, now look at the soft tissue thickness over the distal phalanx of the tuft, and then compare that with this here. You notice that there is an atrophy of the soft tissue besides the blunting of the tuft. So this is early acroosteolysis with soft tissue calcifications. And in the advanced stage, you can see that there is an arthropathy of the distal interphalangeal joints, a narrowing of the joint space, multiple deformities, and of course, the acroosteolysis has progressed. So, an acroosteolysis coupled with calcification in the soft tissues and atrophy of the skin, along with the arthropathy of distal interphalangeal joint, this constellation of findings is what makes the diagnosis of scleroderma. Now, this patient also had swallowing difficulties and breathlessness, and so we did a barium swallow, and in that you can see that there is a dilatation of the esophagus along with a stricture in the distal part, and a CT chest also revealed early changes of interstitial lung disease. Also note the dilatation of the esophagus. So all these were the features of scleroderma. Coming over to the next case, in this case also you see a very early blurring of the distal tuft, the tuft of the distal phalanx, right? This is the early sign of acroosteolysis. But what is glaring in this radiograph is a generalized osteopenia and a trabecular coarsening. And besides that, you can see a subperiosteal resorption over the radial sides of the phalanges. So these findings in themselves in the hand radiograph help you to make the diagnosis of hyperparathyroidism. And if you couple it with another X-ray, like an X-ray of the skull, you see a very classical appearance, the salt and pepper sign, that is due to trabecular resorption. Besides that, also note a few lytic lesions, which are the Brown's tumors in this case of hyperparathyroidism. So in the next case, what do we see? Besides the acroosteolysis, there is a periosteitis, a periosteal reaction, and an involvement in arthropathy of the distal interphalangeal joint. This is the early stage. And in the late stages, you can see this very classical pencil and cup type of a deformity and an arthritis mutilans in which there is a marked destruction of the carpus, the carpal joints out here. So these are the findings which on the hand radiograph itself is sufficient to make a diagnosis of psoriatic arthropathy. Then other conditions in which you can get an acroosteolysis are leprosy. In leprosy, this is a neuropathic type of an acroosteolysis due to the destruction of the nerve endings, and you get a licked candy type of an appearance as you see in this radiograph. Then, if you have a generalized sclerosis along with an acroosteolysis, so what you get here is a transverse or a band type of an acroosteolysis. So this is seen in pycnodysostoses. And just if you notice that the medullary canal is preserved in pycnodysostoses in contradistinction to osteopetrosis, in which the sclerosis occurs at the expense of the medullary canal and the medullary canals are obliterated. And other conditions, if you have an exposure to polyvinyl chloride, such as a person is working occupational history of working in the plastics industry, then the differential diagnosis is narrowed down to polyvinyl chloride poisoning. Then a prolonged exposure to cold conditions. There you have an acroosteolysis with soft tissue swellings in the earlier stages, which can later progress to soft tissue atrophy. Think of frostbite. And you can also get acroosteolysis and cleidocranial dysplasias along with the skull findings and the osteolysis of the distal clavicle, as well as in progeria. So the first condition that we've covered is acroosteolysis, along with the differential diagnosis of scleroderma, hypoparathyroidism, psoriasis, leprosy, frostbite, pycnodysostoses, PVC poisoning, cleidocranial dysostosis, and progeria. The next condition that we come to is an inflammatory arthropathy. So this is a radiograph in the early stage, and this is the radiograph in the advanced stage. So what we notice here is that there is a juxta-articular osteopenia. Then you have erosions involving the proximal joints, right? The metacarpophalangeal joints, you can see the juxta-articular or the periarticular erosions along the bare areas of the joints, along with soft tissue swellings. These are the early findings. And in the later findings, you see there is a joint space narrowing, there are subluxations, and there are flexion deformities. So remember, the proximal interphalangeal joint and the metacarpophalangeal joint involvement with juxta-articular osteopenia and periarticular erosions. These are the hallmark of rheumatoid arthritis. Also note the erosion of the ulnar stenoid out here. Then an acroosteolysis, a pencil and cup deformity, involvement of the distal interphalangeal joints, along with periosteal reactions, is what, as we've already done before, seen in psoriatic osteoarthropathy. Classical punched out erosions, right? Like a rat bite. So these are the rat bite type of erosions with nodularities, nodules, which may be eccentric, asymmetrical. This is very, very classical of gout. Then distal interphalangeal joint involvement and asymmetric joint reduction in joint space, and central erosions giving rise to the gull's wings type of an appearance is seen in erosive arthropathies. Acroosteolysis with soft tissue calcifications and a distal arthropathy, distal interphalangeal arthropathy, classically seen in scleroderma. Then if you have a chondrocalcinosis, like in this case, there is a calcification in the TFCC, the triangular fibrocartilage, along with an arthropathy. Like here you have the joint space reduction and the subchondral cysts. This is classically seen in calcium pyrophosphate deposition disease. Then arthritis that develops before the age of 16 years. You can see here, this is a skeletal, immature skeleton, and you have asymmetric erosion, joint space narrowing with erosions. And here it is a proximal interphalangeal joint which is involved, along with periosteitis and bone remodeling, right? So this is seen in juvenile idiopathic arthritis. So inflammatory arthropathy is the second condition, with rheumatoid arthritis, psoriasis, gout, erosive arthropathy, scleroderma, CPPD, and juvenile idiopathic arthropathy having been discussed under this heading. The next condition that we come to is periosteitis. So if you see a diffuse bilaterally symmetrical periosteitis of the diaphyseal region of the tubular bones with soft tissue thickening and a tender type of a periosteitis, think of hypertrophic osteoarthropathy. Sorry for that. So this is a paraneoplastic syndrome secondary to carcinoma of the lung. However, it can also develop alongside cardiac, hepatic, or intestinal diseases. And if you see a similar appearance, a periosteitis of the tubular bones, but extending up to the level of the epiphysis, and there is no identifiable cause, then think of primary hypertrophic osteoarthropathy, also known as pachydermoperiosteosis. Another similar looking appearance, but again involving only the diaphysis, but in this case, it is a non-tender or a painless type of periosteitis. Then it is seen in thyroid acropathy, which may occur in 1% of treated hyperthyroid patients. Hypervitaminosis A can also manifest with a diffuse solid type of periosteal reaction, as seen in this case in the region of the ulna. So periosteitis, the differential diagnosis can be hypertrophic osteoarthropathy, pachydermoperiosteosis, thyroid acropathy, or hypervitaminosis A. Then cortical or trabecular resorption. So this classically, what strikes you is the generalized osteopenia, the coarse trabecular pattern, the subperiosteal resorptions on the radial sides of the phalanges, and the blurring of the terminal tufts, classical appearance of hyperparathyroidism, which you can make on this hand radiograph itself. And if you couple it with another radiograph, like in this case, the pelvic radiograph, then you can see other types of resorptions, like the resorption within the cortex here. So you can see the intracortical tunneling, which is also called, these are the cigar-shaped type of lucencies. Then the subtendinous resorptions here in the region of the greater trochanter and the ischial tuberosity, and endosteal type resorption along the pubic symphysis, along with a Brown's tumor in this case of hyperparathyroidism. Then a similar coarse trabecular type of a pattern, which gives you a lace-like appearance or a lattice type of an appearance. In some cases, when it becomes cross, it gives a type of a honeycombing. So this type of appearance is very much seen in sarcoidosis, which is a chronic granulomatous disease of uncertain origin and can affect the skeleton in 15 to 20% of the cases. Again, another coarse trabecular pattern because of a trabecular resorption. But in this case, you notice that there is an expansion of the medullary cavity, right? And there is a remodeling and undertubulation of the tubular bones. So if you see, this is again a skeletal, which is an immature skeletal, right? And an expansion of the medullary cavity points to the possibility of a hematopoietic disorder, and in this case, it is thalassemia, right? And another similar condition, you see an undertubulation, you see a post-trabecular pattern, a generalized osteopenia, along with sclerosis, right? See the sclerosis, which was not seen in the previous case, right? And in this case, you can also see the dense metaphyseal bands. So this is a case of sickle cell disease. So post-trabecular resorption, the differential diagnosis can be hyperparathyroidism, sarcoidosis, thalassemia, or sickle cell disease. And the next condition that we come to is a dense metaphyseal band, which can be seen in lead poisoning. Now, dense metaphyseal band can also be seen as a normal variant in children, but remember that if you happen to see this band in the distal ulna or the distal fibula, it is almost always pathological. Other conditions like healing rickets can also show you a dense zone of provisional calcification, besides some findings of rickets like the cupping of the metaphyses here. And sickle cell disease, as I've already shown you, can show you sclerotic metaphyseal bands. Hypervitaminosis D can present with dense metaphyseal band, and other differentials can be normal variant, treated leukemia, recovered scurvy, congenital hypothyroidism, hyperparathyroidism, and torch infections. So this is the differential diagnosis of dense metaphyseal band. Coming over to the lucent metaphyseal band, you can commonly see that in leukemia. See, you can see that this lucent band is here, besides which is superimposed on a generalized osteoporosis, and then you can also see bone destruction or periosteal reactions in leukemia. Besides that, you may see the loss of provisional zone of calcification, which will manifest as a zone lucency in the metaphysis in rickets, besides the classical metaphyseal cupping, flaring, and of course the lucent bands you can see here. Besides that, you can see irregular lucent bands, radiolucent bands in infantile hypophosphatemia, which are extensions of the growth plate into the metaphysis. In this, the vitamin D metabolism is normal, and there is the mineralization is near deficient or nearly absent, and you may also find other features of rickets. Congenital syphilis can also present with irregular metaphyseal lucencies, and in scurvy also you may have lucencies at the metaphysis, which are known as the Trummerfeld zones, which lie just next to the dense zone of provisional calcification at the physis. Besides that, in scurvy, you may also have corner fractures, which are known as the Pelkin's spurs. Other differentials can be metastatic neuroblastoma, torch infections, or normal variants. So, this is the differential diagnosis of lucent metaphyseal bands. The next condition that we come to is the dactylitis. In this case, you can see that there is a soft tissue swelling over the first metacarpal, second metacarpal, and the first web. There is an expansion of the metacarpal, and an irregular, ill-defined lytic lesion is seen with destruction of the lateral cortex. So this is a case of spina ventrosa or tubercular dactylitis. Tuberculosis is a common condition in India, but the dactylitis is a rare skeletal manifestation of tuberculosis and occurs below 6 years of age. The differential diagnosis of dactylitis is an acute pyogenic dactylitis, right? An osteomyelitis, in which there is non-expansile lesion. You see a periosteal reaction, but there is a background, or there is a clinical symptomatology of pain, swelling, and a hot red digit with generalized fever. Besides that, you can also see a similar bone expansion, analytic lysis of the bone in cases of sickle cell dactylitis and also in cases of sarcoidosis. So these constitute the differential diagnosis of dactylitis. Congenital syphilis can manifest with a periosteal reaction, and since I didn't have a hand radiograph to show you, I took the liberty of showing you the tibia in this case. And this is the differential diagnosis of dactylitis. And a few miscellaneous conditions. You see a spade-like hand with ungual tucking, arrowhead type of appearance of the distal phalanx, a metacarpal hook on the radial aspect, an increased joint space due to a cartilage hypertrophy and soft tissue hypertrophy, classical picture of acromegaly. And the thin spider-like elongated fingers are seen in erychnodactyly, which is a commonly seen in Marfan syndrome. So this is what we have discussed here under the headings of acroosteolysis, inflammatory arthropathy, periosteitis, cortical and trabecular resorption, dense metaphyseal band, loosened metaphyseal band, dactylitis, and some miscellaneous conditions. So an astute radiologist would tell the clinician that would give me a good hand radiograph, and I'm going to predict the systemic disease that the patient can suffer from. Thank you for a very patient listening. Thank you so much.
Thank you, Professor Aurora, for your very informative presentation. And then we will move to our second speaker. Our second speaker is Dr. Perami17Sept22HallA from Dr. Karyadi General Hospital, and she is also Vice Dean of Academic Affairs of the Faculty of Medicine, Diponegoro University, Semarang. Dr. Hermina, time is yours.
Good morning, everyone. Thank you for this opportunity for me to present my talk about the role of imaging in seronegative rheumatoid arthritis. Overview of my talk about definition and diagnosis of rheumatoid arthritis, type of rheumatoid arthritis, seronegative and early state of rheumatoid arthritis, radiographic, sonographic, and MR findings. Definition of rheumatoid arthritis is a chronic systemic autoimmune disease which is characterized by persistent inflammatory synovitis leading to cartilage damage, bone erosion, joint deformity, and disability. RA is a chronic inflammatory disease affecting the synovial membrane, which in turn produces swelling, tenderness, and pain of the affected joint. If the disease remains untreated, it can lead to joint damage and bone destruction. RA is a symmetrical polyarticular disease affecting mainly the small joint of the hand and wrist first, as well as those of the feet. Extra-articular involvement is not infrequent, affecting the eyes, lung, heart, skin, as well as other organ systems. The diagnosis of RA is mostly clinical and laboratory, with the application of the ACR and Euler 2010 RA classification criteria, with definite diagnosis requires total score more than same with 6. In this criteria, rates on a scale from 0 to 10 points were assigned to 4 separate domains of sign and symptom, namely joint involvement, serology, duration of symptoms, acute phase reactant. In this criteria, excluded distal interphalanx joint, first carpometacarpal joint, and first metatarsophalangeal joint from this criteria. Clinical presentation of RA in typical course develop over several weeks to months, slow insidious, with constitutional symptoms, fever, fatigue, weakness, loss of appetite, tenderness, warmth, and swelling over affected joint, muscle aches and stiffness, with joint deformity at late stage, polyarticular and bilateral symmetrical peripheral joint involvement. account for 60 to 67%. In atypical course, usually acute mono-oligoarticular asymmetric joint near the trunk account for 33 until 40%. Joint involved in rheumatoid arthritis, peripheral joint and the small joint of hand and feet. Most patients report involvement of small joint first. Classically, DPIP, MCP, and MTP joint, not DIP, followed by the wrist, knees, ankle, shoulder, elbow, hip, temporomandibular, acromioclavicular, and sternoclavicular joint. In the axial skeleton, imaging abnormalities in the articulation of the cervical spine are more often encountered than changes in the thoracolumbar spine or sacroiliac joint. Laboratory NRA in serology, it can be seropositive and seronegative. Seronegative is an early 2000 study. 12 out of every 100,000 RA patients were seronegative, and this number increased to 20 per 100,000 years later. The heritability of rheumatoid arthritis is approximately 40 to 65 for seropositive rheumatoid arthritis and 20 for seronegative rheumatoid arthritis. Acute phase reactant in patients with active disease, acute phase response laboratory tests such as erythrocyte sedimentation rate or CRP may be normal in up to 20 until 25 of cases. Type of rheumatoid arthritis, it can be positive and seropositive and seronegative RA. In seropositive RA, it means positive to anti-citrullineated peptide antibody and or rheumatoid factor blood test. Lifelong symptom and can improve or flare up at time, causing joint swelling, pain, and stiffness. In seropositive RA, it can affect multiple joint involvement symmetrically and more aggressive and severe than seronegative RA. Seropositive RA can be associated with more joint damage, deformity, rheumatoid nodules, development of vasculitis, lung tissues, and extra-articular manifestation. In seronegative RA, it is mean absence of anti-citrullineated peptide antibody and rheumatoid factor blood test with a classic rheumatoid arthritis symptom, but less severe and can unpredictable. Diagnosis is based on sign and symptom of the condition, including morning joint stiffness, swelling, pain, and symmetrical involvement of multiple joints. Systemic symptoms are common, such as fever and fatigue. Rheumatoid nodule, vasculitis, and lung tissues are less likely in seronegative RA. In seronegative RA can be associated with more joint damage, deformity, rheumatoid nodules, development of vasculitis, lung tissues, and extra-articular manifestation. In early stage of rheumatoid arthritis, currently, in general, early RA patients are preferentially regarded as those with symptoms of less than 3 months duration. And the diagnosis can be challenging as the serological can be seronegative and conventional radiological characteristics are often absent. The latest classification criteria SCR Euler 2010 often used to diagnose RA incorporate the role of ultrasound and magnetic resonance imaging to detect of synovitis in the criteria. It can enabling earlier diagnosis and correct classification of patient. Early onset or recent onset rheumatoid arthritis characterized by symptoms lasting less than 6 or 12 months according to different authors. May not manifest soft tissue swelling of 3 or more joints as described in the 1987 classification criteria. In the early state of RA may not necessarily present with unequivocally symmetric swelling, and in the very early stage of RA may not demonstrate serological abnormalities such as elevated acute phase reactants, during which time CRP and ESR are often unremarkable. Modern treatment of the disease requires very early detection and rigid control of inflammatory arthritis. So imaging is important, particularly to identification of early changes, with the emphasis on early diagnosis and treatment of rheumatoid arthritis before irreversible joint damage occurs. This reflects the observation that erosion depression, a late stage in the disease process. One of the earliest detectable changes in patients with rheumatoid arthritis is proliferation of the synovium, the rheumatoid penis. Ultrasound and MRI are sensitive for the detection of synovitis, and both are superior to radiography. So the abnormalities in early RA included synovitis, tenosynovitis, bursitis, bone marrow edema, and adipose tissue inflammation. Joint effusion is seen early in the disease process in RA and is common associated with synovitis, tenosynovitis, and bursitis. Bone marrow edema accompanies synovitis in the majority of patients. However, it could be the only area involved in early RA. The progression of RA in the invasion of the penis of the joint hyaline cartilage and its subsequent damage is seen as subchondral point erosion formation and cartilage space narrowing, and the end can be structural deformity. Rheumatoid arthritis is typically represented as synovitis, tenosynovitis at the level of the hand and feet joint, bone erosion of small joint, and the end structural deformity of bone in joint. In early RA, peripheral synovitis occur in peripheral within the joint in the pair area. And in progression, penis can be hypervascular, is feature of early and active RA. In long-standing, the penis across the entire articular surface of the involved joint, and can be as fibrous penis tend to predominate in long-standing RA. And the progress of cartilage loss and bone erosion and can cause a deformity of the bone and joint. To diagnose RA, it is a systematic approach with multimodality imaging characteristic based on alignment, bone changes, bone density and erosion, bone marrow edema or osteitis, cartilage damage, and distribution. Radiography. Imaging findings separate the disease into early stage RA. This is a non-specific periarticular soft tissue swelling with a fusiform configuration and periarticular osteopenia. Soft tissue swelling occur from a combination of joint effusion, edema, synovial enlargement, venous formation, and or tenosynovitis. Periarticular osteopenia typically become more generalized as the disease progresses. Initially, the small joint may widen as a result of effusion. And an early set of RA can be normal appearance on radiography. Classic finding of rheumatoid arthritis, marginal erosion herald classic finding of RA. Erosion usually begin at the intracapsular articular margin, a region of exposed bone within the joint capsule and the start of the cartilage surface. This area of uncovered bone is termed the bare area. Erosion are visible on plain radiograph as a break in the cortical bone surface and are often accompanied by loss of the adjacent trabecular bone. The figure is show the erosion. And late radiographic finding can be expansion of the marginal erosion toward the middle of the joint, articular mutilation, cup and saucer deformity, and can be articular ankylosis, often formation as an os carpal. Ultrasound and MRI. Advantages of ultrasound and MRI are more sensitive than clinical examination for identifying minimal synovitis and can aid diagnosis when there is a diagnostic doubt. Can detect inflammation and can predict progression to clinical RA from undifferentiated inflammatory arthritis and for ACPA positive non-specific symptom. Subclinical synovitis detected by ultrasound and MRI predict subsequent remits and flare, even when clinical remission is present, and also may be used to predict treatment response and be useful in monitoring disease activity. And MRI is more responsive to change in jointiness than CR and can assist in monitoring of disease progression. MRI is more sensitive than clinical examination and can detect bone marrow edema, which is a strong predictor of subsequent radiographic progression in early RA. This is a ultrasound picture with a level of the second metacarpal demonstrating of synovitis of the extensor tendon of the hand. And the next figure is the level of the second metacarpophalangeal joint shows synovial hypertrophy with an early erosion. With a Doppler ultrasound demonstrating positive Doppler activity in the tendon sheath in keeping with active disease. This is the figure show ultrasound finding in different patients with newly diagnosed RA with hypoechoic synovial thickening at the metacarpophalangeal joint, proliferative penis with underlying bony erosion in the distal radius, and synovial hypertrophy around the scaphoid, wavy hypoechoic fluid in the flexor tendon sheath, and tenosynovitis, intrasynovial and perisynovial increased vascularity. Same with my patient. This is also in female, 55-year-old with periarticular arthritis with a rheumatoid factor negative. We can see the thickening of synovial in metacarpophalangeal in hand, left hand and right hand, and also we can see the fluid collection peritendon, tenosynovitis. The next patient in my hospital, female, 53 years old with joint pain, stiffness, and swelling with rheumatoid factor negative. On conventional radiography, we can see a periarticular osteoporosis with no evidence of joint narrowing or soft tissue swelling. But in the ultrasound, we can see the thickening of synovitis and in MCP in right hand and VIP in right hand. The next patient is male, 39 years old with joint pain, swelling, hand and feet with rheumatoid factor negative. We can see also periarticular osteoporosis, osteopenia, with no evidence of narrowing of joint and soft tissue swelling. Then in ultrasound, we can see the synovitis in an MCP, in PIP in the right and left hand. This is thickening of synovial or synovitis, and power Doppler of in the synovitis that can be grading with grade 0, 1, 2, and 3. MRI. MRI finding of FE. With the growing role of MRI in early diagnosis, it is ability to detect and characterize of involvement of the synovial membrane and to identify erosion and changes of subchondral bone edema. One of earliest detectable changes in patients with rheumatoid arthritis is proliferation of the synovium, the rheumatoid venous. Both ultrasound and MRI are sensitive to detect of synovitis, and both are superior to radiography. The diagnosis of synovitis by MRI is based on 3 criteria: increasing size on the synovium, increasing water content of the joint, and the increasing signal of the synovium after intravenous contrast administration. What is synovitis? Synovitis can be diagnosed with use of gadolinium-based contrast, allow for the differentiation of synovitis from joint effusion or tenosynovitis, as well as for the diagnosis of bone marrow edema and erosion. Synovitis is often less bright on fluid-sensitive sequences compared with joint fluid. Without contrast and administration, joint fluid and proliferative synovitis cannot be easily differentiated. Subsequent sequences using fast skin echo, short tau inversion recovery, and T2 weighted image with fat saturation without contrast have good concordance. Synovitis MA characteristic. In the T1 weighted image, it shows intermediate to low signal intensity, whereas due to the increased water content of synovitis, so in T2 weighted image, it has high signal of hypervascular synovium as well as the low signal characteristic of fibrosis. With the contrast enhanced T1 weighted images are sensitive and specific in the assessment of acute synovitis. The use of fat suppression increased visual contrast between the inflamed synovium and adjacent structure of contrast enhanced T1 weighted image. So we can use T1 fat set weighted image in contrast. For the evaluation of synovitis in early RA, we use coronal gadolinium enhanced fat suppressed T1 weighted image from both hands. The hand was chosen for MR assessment given that is the most clinically affected area in rheumatoid arthritis. You can see the synovitis around the bone and also fluid collection here, tenosynovitis in the level of carpal tunnel. Bone marrow edema on MR. Bone edema is visualized as a lesion within the trabecular bone with ill-defined margin and signal characteristic consistent with increased water content. Bone edema may occur alone or surrounding an area of erosion or other bone deformity. In this figure, we can see the hyperintensity within the bone with a ill-defined margin. This bone erosion is reflect the observation that erosion depression a late stage in the disease process. MRI bone erosion is visualized as sharply marginated bone lesion with correct juxta-articular localization and typical signal characteristic. For instance, loss of normal low signal intensity of the cortical bone and loss of normal high signal intensity of the trabecular bone on T1 weighted image. Erosion is a sharply marginated bone lesion visible in two planes with a clear cortical break visible in at least one plane. So this is a differences between bone erosion and bone edema. In this figure, we can see MRI finding with RA, and it can be show erosion. And this is edema also with synovial thickening, with tenosynovitis, with tenosynovitis and extensive proliferative panels on T1, which is image, and fat set T2, which is around a distal ulna. With involvement of the extensor carpi ulnaris tendon in axial image, fat set T2 with its image showing inflammatory changes around the third metacarpal head and corresponding flexor tendon on figure G. The next patient imaging finding in a 29 years old female patient diagnosed with early RA, including radiograph, power Doppler, ultrasonography, and on MR. With on radiography, there is no structural damage on radiograph, and on ultrasound shows diffuse synovitis and tenosynovitis. And on MR, we can see bilateral symmetrical synovitis and tenosynovitis, and osteitis in the bone with bone marrow edema on coronal fat suppressed T2 with its image. This is my patient, is also with negative, seronegative RA with a synovitis, tenosynovitis, synovitis and tenosynovitis. And also we can see the bone marrow edema. Utility of various imaging modalities and rheumatoid arthritis, we can see in early changes. So the ultrasound and MRI have good advantages to detect the pathology in early changes. So in conclusion, in seronegative and early RA related pathologies include thickening of the synovium of the joint capsule, tendon sheath, and bursae. Joint effusion and bone marrow edema are seen early in the disease process in rheumatoid arthritis and is commonly associated with synovitis, tenosynovitis, and bursitis. Even though radiography continues to be the mainstay for the diagnosis and follow-up of the patient with RA, it has been proven by many investigators that ultrasound and MRI are more sensitive in detecting early and persistent changes of RA. Thank you for your kind attention.
Thank you, Dr. Hermina, for your very comprehensive presentation. And then we will move to our third speaker of this session, Dr. Sept22HallA from Hamad General Hospital, Doha, Qatar. Dr. Sept22HallA, time is yours.
Good morning. My name is Sept22HallA. I am MSK radiologist in Doha, Qatar. Today I am going to speak about spondyloarthropathy, that is called in short form SPA. No conflict of interest. Today I will discuss about the subchondral edema, especially seen in the stereo MRI sequence. So this is subchondral edema in spondyloarthropathy. This is subchondral edema in the mechanical changes, and this is infection. So hope at the end of this study, end of my lecture, we can able to differentiate it easily. It is quite challenging. Sometimes this subchondral edema mimic very much similar to other diseases also. So subchondral edema seen in the spondyloarthropathy, also seen in the mechanical changes, osteoarthritis condensa ilii. Even septic arthritis also appear sometimes similar, and some normal variant of the SI joint also have subchondral edema. Then we'll discuss about the imaging feature of the SPA, and we'll discuss about the SI joint, which is very interesting. Spondyloarthropathy have two types of manifestation, which is axial manifestation. We call it axial SPA, which is mainly involving the spine and SI joint. And peripheral manifestation is mainly to the joints, distal joints, finger, hands, and foot. According to the assess criteria, there are two arms. Any patient with HLA positive needs more than two spondyloarthropathy features. So these are the spondyloarthropathy clinical features like inflammatory low back pain, arthritis, enthesitis, which is quite common, dactylitis, uveitis, then skin disease, we call it psoriasis, inflammatory bowel diseases, then family history of spondyloarthropathy, and some patients are HLA-B positive, and then lab findings, there will be high CRP. So if any patient has in MRI or X-ray sacroiliitis, he needs only one clinical feature of the spondyloarthropathy. If somebody has HLA-B27 positive, he needs two or more clinical features of a spondyloarthropathy. That means the spondyloarthropathy is very much clinical diagnosis. SI joint is very interesting joint because there are two types of joints here. The anterior part, which is synovial, and posterior part, which is ligamentous. So the joint which is synovial are of the interest because here this condyloedema will be the spondyloarthropathy. Even sometimes ligamentous area edema will enthesitis, but quite rare. Subcondyloedema mainly in the synovial joint. So in the plain X-ray, it appears like a C shape. And sometimes there are two lines because if you see in the CT scan, this is like slant. Even in the superior aspect, it is like a oblique, then it is like curved, reverse C, then again slant. So very complicated anatomy. That's why in X-ray we have two lines, one on the lateral side, which is the anterior part, and one medial side, which is the posterior part in X-ray. This is the modified Ferguson view, which we make caudal angulation about 30 to 45 degree, and we get a straight line, so it's slightly better. And here you can see there is subcondylar sclerosis in the modified Ferguson view. MRI is very sensitive in detecting subcondylar edema. X-ray takes around 5 to 7 years to detect subcondylar sclerosis. This is modified New York criteria for the sacroiliitis. So we have grade 0 to grade 4. The most important is grade 2, where we'll find there is a subcondylar sclerosis. There is some joint erosion. And here we can able to diagnose sacroiliitis. Grade 1 is suspicious lesions. Grade 0 is normal. Grade 3 has significant subcondylar sclerosis, some joint widening and erosions. And grade 4 is ankylosis. SI joint, the sequences are quite easy. Normally we have to do coronal images and we need to do fat set. The best fat set is the steer sequence, which is very nicely fat sets, homogeneous fat suppression will get it. That's why we need to do steer sequence, coronal, and T1 without fat set, coronal. And we have to do axial images, same, the steer and axial images, the same sequences, T1 without fat set and steer. Normally, we need only two sequences. In some institutions, they do Dixon T2 and also some diffusion. But these two are most of the centers we do only T sequences. Contrast is not needed in most of the cases. So MRI features of spondyloarthropathy. So there are two types of lesions. One is acute inflammatory lesions, which is bone marrow edema, capsulitis, synovitis, and joint fusion. And there are some, we call it structural lesions like bony erosions, periarticular fat deposition, or we call it fat metaplasia. Then we call it subcondylar sclerosis. Then backfill, which is discovered in last 5 to 6 years, which is within the SI joint. When ulcer heal, makes a like T1 bright signal that's called backfill. We'll discuss also, and ankylosis. So these are the structural lesions, and these are the acute lesions. The acute lesions, bone marrow edema, is not specific for the spondyloarthropathy. It can seen in spondylopathy in mechanical changes, stress changes, osteoarthritis condensa alii, septic arthritis, some anatomical variant causes stress. We can see there also, and some other causes also. So we'll discuss this all cases. The positive MR for spondyloarthropathy is subcondylar edema seen more than 2 contiguous slices, or if there is once in the one slice, then should be seen in more than one region, like in the right side, left side, superiorly, inferiorly, more than one region, then is positive. And negative is only in small area less than 1 centimeter at the corner. They are a negative for spondyloarthropathy. We will discuss by case by case. This group has defined the active sacroiliitis MR classification in spondyloarthropathy. So in this case, this is the steer coronal images. You can see there is a subcondylar edema here. Then also 3 places in the one slice. So this is positive MRI for the spondyloarthropathy. Here seen only in one cut. That's also seen only in the peripheral part. So this is negative for the spondyloarthropathy. Here there is another different type of things that this patient has subcondylar edema. Then there is a white signal within the joint. So that is joint diffusion synovitis. And here in the steer, again here the subcondylar edema and some synovitis. And in the T1, we can see some fat metaplasia, subcondylar sclerosis. So there are so many features. So this is positive for spondyloarthropathy. On the other hand, here we can see at the corner there is only one focal small subcondylar edema, very small subcondylar edema. So this is negative for the spondyloarthropathy. Let us discuss the case 1. So in the X-ray, I can see there is subcondylar sclerosis. There is subcondylar sclerosis bilateral. So this is according to the modified X-ray criteria. This is grade 2. So see this steer MRI sequence. So we can see subcondylar edema bilateral. Even there is a synovitis, joint diffusion, subcondylar sclerosis. So this is, and there's also at the surface which is capsule. There's edema. We call it capsulitis. So this is very easy case of spondyloarthropathy. We call it SPA. So this is spondyloarthropathy. So spondyloarthropathy should have edema, bilateral or unilateral significant edema, subcondylar edema. Then there's a capsulitis. There's a joint diffusion synovitis. Thus we call it spondyloarthropathy. What is capsulitis? So on the surface of the SI joint, there is a capsule. Inflammation of the capsule is seen as a T2 bright signal. So normally thickness is about 5 or less than 5 millimeter. So capsulitis is not specific, also seen in the infection and some other conditions. This is capsulitis, subcondylar edema, synovitis. So this is spondyloarthropathy. Let us see the case 2. So here in the X-ray, I can see only the subcondylar sclerosis, this area. And in the MRI also, the steer sequence, there is a subcondylar sclerosis and subcondylar edema only in the anterior superior part of the joint. The middle part of the joint is normal. So this is not a SPA. This is mechanical changes, or even the osteoitis condensa ilii in early phases appear same. So this is not spondyloarthropathy. This is mechanical changes. So what are the conditions where you can see the mechanical changes? Most of the time we have, like in this case, this is unilateral sacroiliitis, unilateral sacralization. There's abnormal communication with the lumbar with the sacral vertebra. We call it unilateral sacralization. So this is abnormal articulation that can lead to, there is some stress here, and this is subcondylar edema. So this is mechanical changes. And the common site is the anterior part of the SI joint. So in this area, this is the sacrum, this is the most anterior part. So that is seen in the first cut of the coronal image, the coronal images. Where the SI joint is normal, we can see subcondylar edema in one or images. So this is typical mechanical changes or osteoarthritis, or even sometimes osteoitis condensa ilii we see. See the case 3. This is the X-ray, and I can see the triangular subcondylar sclerosis mainly in the ilium. Bilateral triangular subcondylar sclerosis. The joint is normal. It's the same patient's MRI. This is T1. I can see the subcondylar sclerosis in the ilium. Joint is normal, bilateral. There are some subcondylar fatty changes also seen here. Even in the steer sequence, I can see some little edema also around the sclerosis. So this is typical osteoitis condensa ilii. This is not a SPA. So the osteoitis condensa ilii, which is always secondary to some stress, that most likely sometime post-delivery or always post-delivery. This typical triangular area of the sclerosis in the ilium. So that we call it osteoitis condensa ilii. SI joint will be normal. Case 4, this is CT scan. We can see there is a triangular subcondylar sclerosis with the normal SI joint. So this is osteoitis condensa ilii. This is not a SPA. Let us see this case, which is case 5. So here I can see there is a edema in the capsule. There is mild subchondral edema also seen. There is a joint effusion. And the most important feature is there is an edema under the iliacus muscle. So this is the most important to diagnose infection. So this is infectious sacroiliitis or septic arthritis of the SI joint. So this is here the take-home message is there. If edema extend to the soft tissue under the muscle of iliacus, think of infection. And normally it is always, most of the time is unilateral. Another case, there is subchondral edema. There is a joint effusion, capsulitis, soft tissue edema in the piriformis muscle, midasmine. And there is and most important thing is that this is the iliacus and edema under the iliacus muscle. So this is the diagnostic point in infectious sacroiliitis. Then can be different etiologies, can be bacterial, can be tubercular, but this soft tissue edema in any infection is important. So here there is a subchondral edema, there is some capsulitis, but soft tissue edema and edema under the muscle is the most important for the infection. So this septic arthritis. There's one paper where they said that capsular thickening more than 5 millimeter, capsular thickening more than 5 millimeter goes in favor of infection. And here also the same, this is subchondral edema, synovitis, and edema under the even there's this abscess collection under the muscle. Another important point for the spondyloarthropathy is concomitant presence of many findings. Like here, there's subchondral edema, there is a synovitis. Suppose there's some erosion. So all this combination of findings in the favor of spondyloarthropathy. In this case, this is T1 without fat set, and there is a fat. We call it subchondral fatty changes or fat metaplasia. There's subchondral sclerosis, and they are tiny erosions. Erosions better seen in the CT scan. So these are the tiny erosions. We call it stump-like. Okay. So let us discuss about the backfill. What is backfill? When the erosions healed it by fat deposition or by other material, become T1 bright signal. So here this is the T1, and you can see there is a bright signal within the SI joint. These are the backfill. So this is sign of filling before the ankylosis. So again, these are the ankylosis, and these are the T1 bright sign. So this is backfill, and this is ankylosis. As I told you before, there are concomitant presence of other findings, like here there is subchondral edema, some ankylosis. So this is spondyloarthropathy. This is again, this is periarticular fat deposition or fat metaplasia. X-rays are also very important. So that's why I have included some X-rays. So here, this is the vertebral body, and this is the annular fibrosis where there is a calcification. We call it syndesmophytes. So syndesmophytes are very diagnostic of the spondyloarthropathy and ankylosing spondylitis. So here also there is a decreased joint space ankylosis, syndesmophytes. So this is very typical of spondyloarthropathy or ankylosing spondylitis. Sometimes you may confuse with the one dish that I'm going to how to differentiate dish and SPA. I will tell spondyloarthropathy. I will tell you. So this is the one case where this is T1. So this is the subchondral fatty changes and ankylosis. Steer against this fatty changes or ankylosis. So this is spondyloarthropathy, or you can see the X-ray. This is typical ankylosis of ankylosing spondylitis. So we check another case. So this is the SI joint. Here there is a edema, which is quite large. And the same patient has also subchondral edema. There are erosions, joint space widening, subchondral sclerosis, erosion, subchondral sclerosis. And another thing in the spine is that in the posterior element, there is a enthesitis. So whenever there is a ligamentous attachment, in that area, there is a T2 bright signal. So these are in enthesitis. So this is also typical of a spondyloarthropathy. another case. So this is, they have done hip MRI. This is chest sequence again. There's some joint diffusion, bilateral. And you can see there is a bilateral subchondral sclerosis, subchondral edema. And this patient has SI joint or lumbar spine MRI also. And in the lumbar spine, we have typical end plate edema, which is we call it Anderson lesion. Then you can see there is an enthesitis in the facet joint and the posterior ligament. So this is again spondyloarthropathy, SPA. There is a nice paper by same SAS working group. So they have described in great detail about the enthesitis. So this in the ankylosing spondylitis, we call it corner lesions or Romanus lesion. Most of the paper they say should be have more than 4 vertebra. So that is important. And this we call it Romanus lesion, the edema in the corner of the vertebral body. Then patient, this patient have also end plate edema, that is we call it Anderson lesion. Another paper also said the edema in the anterior part of the vertical edema is very diagnostic of spondyloarthropathy. This is very diagnostic of spondyloarthropathy. No other disease can have edema like this. So these are the enthesitis, very typical enthesitis in the posterior ligament. So these are the spondyloarthropathy. This is the X-ray of the same patient. So this is ankylosing spondylitis with ankylosis of the SI joint. So how to differentiate ankylosing spondylitis with diffuse idiopathic skeletal hypostosis? So dish is normally have flowing ossification. So this is vertebral body, and this is the syndesmophytes. So it is exact in the margin. When there is a ossification, which we call it flowing ossification, that goes around 2 millimeter around the vertebral body. So it will be like this, away from the vertebral body. That is flowing ossification. That is diagnostic of dish. And normally dish happen at the lower lower thoracic spine, end of the T12. And our spondyloarthropathy ankylosing spondylitis start in the sacrum and in the lumbar area. So this is the syndesmophytes. These are the syndesmophytes. Again, these are the syndesmophytes. And there's ankylosis. So again, I will repeat. The syndesmophytes are normally on the annular surface of this vertebral margin. On the other hand, dish, which is diffuse idiopathic skeletal hypostosis, is a little bit away from the margin. This is joint ankylosis. And sometime in the posterior part of the SI joint, which is a ligamentous, there will be edema around that. That is enthesitis. Here also we can see this is the ischium and the hamstring tendon attachment. There is edema around it. So this is the enthesitis. Sometimes nominal variant of the SI joint causes stress and there's lead to subchondral sclerosis, chondral edema. So here there is the accessory SI joint that can have some sclerosis and edema in the MRI. So we should able to diagnose the accessory SI joint. Normally is at the level of S2. And there is also another variant, we call it iliosacral complex, that also causes stress and subchondral sclerosis and edema. There is another variant, we call it bipartite iliac plate. There is sometime also we can confuse with the hyperparathyroidism, because there is a subchondral bone resorption. This appear like a widening of the joint. So we should have some lab findings also with us. So this is hyperparathyroidism. As I told you, nowadays also we can do T2 Dixon and diffusion, which has some new papers coming that have an advantage over our normal steer sequence and T1. So the take-home message conclusion is that if there is a significant edema in the subchondral area with joint diffusion synovitis capsulitis, that is a spondyloarthropathy. If the edema is only in the superior inferior part, small, limited to the 1 images, these are often mechanical changes or not SPA. And if you get edema in under the muscle, capsulitis, soft tissue edema, this is infection. Thank you very much.
Thank you, Dr. Alam, for your very interesting presentation. And then we will move to our last speaker of this session, Dr. Sonal Saran from All India Institute of Medical Science, Rishikesh, India. Dr. Saran, time is yours.
Hello everyone, I am Dr. Sonal from AIMS Rishikesh, India, and I want to thank the Asian Musculoskeletal Society for providing me this opportunity to speak on this platform. So for the next 20 minutes, I will be speaking on newer concepts in idiopathic inflammatory myopathies. So before going further, let's just see the basic muscle architecture that we studied in our first Prof MBBS. And what we can see here is a muscle which is composed of muscle fascicles which are grouped together. So we can see the entire muscle is covered by epimysium, and the group of muscle fascicles is covered by perimysium, and the single muscle fiber is covered by endomysium, and there are fibrovascular septa between the group of fascicles. And in this image, we can see the axial cut of the leg showing different grouping of the muscles. So we have muscles in the anterior compartment, lateral and posterior compartment. Like this, we have muscle groups in other parts of the body. And when we talk about inflammatory myopathies, it identifying the target site for biopsy is another goal of imaging. Assessing the chronicity. So presence or absence of atrophy will suggest chronicity, and evaluating any concomitant pathology, like some inflammatory myopathies are associated with malignancy. So if we are doing imaging for the inflammatory myopathies, we may encounter some associated pathology like tumor. Monitoring the temporal evaluation of evolution of disease on follow-up scan is another goal. So when we talk about imaging, conventional MRI is the gold standard imaging modality that we use for evaluating the inflammatory myopathies. And we have some additional functional sequences in MRI that we can use while evaluating inflammatory myopathies. Besides MRI, we have ultrasound, specifically the ultrasound. MRI, we have ultrasound, specifically the ultrasound elastography, and there are some articles which suggest use of FDG PET also. When we talk about conventional MRI, we can do conventional MRI in many ways. So there are many studies and there are many centers which use whole body MRI for evaluation of inflammatory myopathies. Then we have restricted whole body MRI, in which we don't take the MRI of entire body because it is very time consuming process, and we take only the coronal and axial cuts of bilateral upper limb and lower limb. So that is restricted whole body MRI. Then we can take MRI of bilateral thigh, which is in our opinion, it is the best way to evaluate inflammatory myopathies, and there is no convincing evidence in the literature of the whole body MRI better than the MRI bilateral thigh in evaluating inflammatory myopathies. Use of contrast is debatable, and we don't generally recommend the use of contrast only in cases when we are suspecting any focal pathology or infection. Then we can use contrast. Otherwise, there is no use of contrast. When we talk about the scanner, 3 Tesla and 1.5 Tesla scanners, both are equally good. When we talk about sequences, coronal and axial stir and T1 weighted sequence are the basic sequence that we use in MRI while evaluating inflammatory myopathies. So stir is basically to see the edema, and T1 weighted sequence is to see the atrophy. So here we can see whole body MRI, and we can see these muscle groups which are showing edema. We can also see involvement of the subcutaneous plane, which are also showing edematous changes. So this is a case of dermatomyositis, and in this way we can do whole body MRI. But whole body MRI takes approximately 50 minutes, and it is really a time-consuming scan. This is a bilateral thigh MRI coronal stir, where we can see this is a case of normal patient, and here we can see subcutaneous plane, muscles, and bone. So if there is any pathology, we can very nicely see here. This is the axial cut of bilateral thigh, and it's the T1 weighted sagittal axial sequence. This is star sequence, and we can see how the muscles and subcutaneous plane look on axial star and on axial T1 weighted sequence. So if there is any kind of inflammation, it will appear as hyperintense, and if there is any fatty atrophy, we can see replacement of the muscle fibers by fat, which will appear hyper intense on T1 weighted sequence. So what do we basically see on MRI? So first thing is edema, which is hyper intense on star or T2 weighted fat suppressed sequence, and star is better than the second one. It can involve muscle, facial or perifacial planes, subcutaneous tissue, and skin. It can be diffuse homogeneous, high signal, or it can be foggy or honeycombed. Then we can see muscle atrophy, which is best assessed on the T1 weighted images. It is almost always associated with fatty infiltration. It can be symmetric, asymmetric, or it may involve a specific muscle group. And when there is muscle atrophy, we get this undulating fascia sign. So here we can see this is undulating fascia sign because of atrophy in the quadriceps group of muscles. Sometimes we get high signal intensity on T2 without any inflammation. So there are some situations in which we can get high signal intensity on T2. So in normal patients, we can get hyper signal in the distal region of medial gastrocnemius at their attachment over the soleus. Chemical shift artifact can lead to abnormal hyperintensity. In damaged muscle where there is fatty infiltration and depending on the fat suppression technique, muscular tissue which is degenerated by fat can show slightly hyper signal than the normal muscle tissue. Post-exercise, we can have hyperintensity on T2, then deep vein thrombosis, sickle cell crisis, and muscle infarction in diabetic patients can lead to abnormal hyperintensity. Intrinsic and extrinsic trauma, post-radiation, biomyositis, and denervation can also lead to high signal intensity on T2 without any inflammation. So now we're seeing the difference between three important inflammatory myopathy groups. So talking about polymyositis. So polymyositis shows symmetrical and proximal predominance, and there is often diffuse, homogeneous, high signal intensity without atrophy. And posterior compartment of thigh is most commonly involved. And facial edema is plus minus. It is not necessary that we get facial edema in polymyositis. Whereas in dermatomyositis, we get symmetrical and proximal involvement, but there is significant subcutaneous and facial edema. As the name indicates, dermatomyositis involves the skin. Anterior compartment is more frequently involved than the posterior one. And muscle edema can be peripheral, in peripheral distribution, giving honeycomb appearance. Inclusion body myositis generally have asymmetric involvement and distal predominance. There can be isolated atrophy without edema. So you will find a lot of atrophy in inclusion body myositis. Flexor digitorum profundus and quadriceps involvement is characteristic. Facial edema is absent and we get undulating fascia sign because of significant atrophy. So here we can see, this is a video clip where we can see diffuse hyperintensity in all the muscle compartments in bilateral thigh. And we can also see involvement of the subcutaneous tissue, right? And this is the T1 weighted sequence where we can see there is not much atrophy in the muscles. There is mild atrophy with involvement of subcutaneous and tissue and the skin. So this is a case of dermatomyositis. This is another case where we can see diffuse homogeneous hyperintensity in bilateral thigh. Muscles are involved, but skin and subcutaneous tissue is relatively spared. Again, we can see there is not much atrophy. This is a case of polymyositis. Now, let's talk about how to score edema and fatty atrophy on MRI. So there are many articles, there are many studies, and many authors have studied different ways of scoring edema and fatty atrophy on MRI. So some methods are semi-quantitative, which are relatively easy and practical, and some are quantitative method. So in semi-quantitative method, what I found, this study, Anderson et al. In 2017, they scored muscle edema in a very practical way. So they not only scored the extent of the edema, but they also scored the signal intensity. And fatty infiltration can also be scored, and this is quite easy and practical to apply in daily practice. Whereas quantitative methods are slightly difficult and time consuming, and in routine clinical practice, it is difficult to use quantitative methods of scoring edema and fatty atrophy. Some methods depend on the computer analysis of pixel intensity values. Some methods use Dixon method, which acquires proton density weighted gradient echo images with different echo times. And T2 mapping can also be used for scoring fatty infiltration and edema. Now, next is DWI. So we know use of DWI in different parts of body and different pathological conditions, but in idiopathic inflammatory myopathies also we can use diffusion weighted sequence. So DWI allows to analyze random water movement in tissues in order to help determine tissue structure. This can be quantified by the apparent diffusion coefficient or ADC. And what we get is several studies, they have analyzed ADC in muscle from myositis showing higher signal intensity in edematous muscle. which even did not show T2 signal changes. So they are better in detection of low-grade edema. They are better than the T2 weighted sequence. And diffusion can also be useful for monitoring the disease, as ADC is increased in active cases and reduced in cases of fatty infiltration. So this is an important point to note. So we can see many studies are published on use of DWI in assessing inflammatory myopathies. We can see in this study, DWI detected more muscle edema compared with the STIR. And in this study also, ADC showed strong positive correlation with the action potential in myositis patient. We can see this video in which we can see DWI sequence in axial plane, and can see a lot of hyperintensity in the muscle groups. And this is how we can take ADC. We can draw an ROI and we get the average value. And what we see is ADC is elevated in cases of active myositis, and it is normal in, here we can see the normal value. Now let's move towards DTI. DTI is an advanced functional MRI technique that we use for imaging of fiber bundles in white matter and peripheral nerves that we have studied in past. And it assesses the anisotropic diffusion characteristic of tissue. So it depends on, because skeletal muscle fibers are cylindrical and they are well ordered like the white matter tracts in brain, and they are actually along a specific direction, where longitudinal axis is longer than the transverse, like we see in white matter tracts. So therefore, the diffusion of water molecules is faster along the longitudinal axis than along the transverse axis. And that's why we can use DTI for evaluation of inflammatory myopathies. So based on these theories, DTI can be successfully applied in the evaluation of skeletal muscle with quantitative measurements of the muscle microstructure and physical function. So we can place an ROI and we can calculate ADC, 3 eigenvalues, and functional anisotropy. So again, there are some studies which have used DTI for muscles in cases of inflammatory myopathies, and they have found that ADC and eigenvalues, they are higher in cases of inflammatory myopathies as compared to the unaffected muscles. So this is a case in our center where we placed ROI on DTI software, and we measured the FA minimum, middle, and maximum eigenvalues. Next is conventional B-mode ultrasound. So ultrasound can detect typical myositis features like edema, calcification, atrophy, facial thickening, and degenerative process, which can indicate fibrosis or fatty infiltration. So ultrasound depends on the echogenicity, and we get either reduced echogenicity or increased echogenicity. So when the echogenicity is reduced, it is because of edema, and that occurs in the acute phase of or active phase of myositis. Whereas when the echogenicity is increased, it indicates atrophy, which occurs in chronic phase. Besides conventional ultrasound, we can use functional ultrasound with the power Doppler, use of power Doppler, but it has a limited role because the Doppler signals are often absent or very low in normal muscles. Second, we can use contrast enhanced ultrasound, which is more sensitive to blood flow within the capillaries. And increase in muscle perfusion was reported in patients with edema on MRI and histologically confirmed diseases. So there are some studies which have made use of contrast enhanced ultrasound. It can help in guiding diagnosis by biopsy planning and assessing the typical active myositis. We can also use ultrasound elastography by direct quantification of tissue elasticity or stiffness, where lowered muscle stiffness is seen in idiopathic inflammatory myopathies. And more recently developed shear wave elastography can also be used extensively in skeletal muscles. Next is FDG PET. So FDG PET has also been explored in cases of inflammatory myopathies, and there are some studies. So here we can say FDG uptake was observed in 82% of patients in PM and DM, whereas 7% of control patients. So it has high sensitivity and specificity in detection of inflammation in muscles. Here also we can see the inflamed muscles shows diffused patchy or marginal signal abnormalities on MRI, but FDG uptake was high in cases even when the MRI was not showing much abnormality. Recently, association with COVID has also been explored. So there are some isolated case reports where inflammatory myositis was triggered because of COVID, and COVID-19 infection can induce myositis with severe muscle weakness. So concluding, muscle imaging and especially muscle MRI is a powerful technique for IIM diagnosis and follow-up. Thigh muscle MRI is a good technique, but it must be used in collaboration with the clinical and biological parameters. Then it is also useful to follow patients, and it appears that the main limitation is the definition and assessment of MRI changes. So sometimes when we evaluate the edema and fatty atrophy, it becomes subjective. So we can actually use scoring that I have already shown, the semi-quantitative method of scoring that we can use and reduce subjectivity. So we can also explore quantitative measures and development of new techniques for making the MRI assessment more practical. So there are some recommendations of MRI in inflammatory myopathy. So first is why perform an MRI? So to rule out IIM diagnosis, so if there is no muscle edema and the enzymes are also normal, so despite of the weakness, you can rule out the inflammatory myopathies. MRI is also useful to guide the muscle biopsy when it is required. And MRI is important in its follow-up to see, to discriminate the muscle damage from muscle disease activity versus steroid treatment. Sometimes in amyopathic dermatomyositis, you may get subclinical inflammation, which is seen as hyperintensity in muscles on MRI, and clinically, the patient does not have any muscle weakness. So you can also see subclinical inflammation on MRI. How to perform an MRI? Pelvic and thigh muscles MRI with T1 and T2 stir sequence are sufficient in routine. We don't need whole body MR. Gadolinium injection is not recommended, and it is not whole body MR is not recommended in routine use. Limitations are definition of hyper signal is subjective, and if it is not quantitatively measured, which is generally not done in routine. And hypersignal may be an artifact, and T2 hypersignal is not specific for muscle inflammation. Thank you.
Thank you, Dr. Sunil Saran, for your interesting presentation. Now we are going to have lunch break till 1:20 p.m. And afterward, all participants can enter Hall A and Hall B again for our last breakout session for today. Hall A will cover spine imaging and Hall B will cover lower extremity imaging, each with 4 of our distinguished AMS speakers. In the meantime, please take your time for a break, and also please come to our exhibition hall and also to our free poster presentation. Thank you. I'm Karika Salama. I'm signing out now, and have an enjoyable webinar.
the time is yours.
Hello, my name is Stephen Wong from Singapore. I'm talking about basics of spine imaging, or to be precise, MR imaging of the spine. So let's get back to the basics. We need to talk about the nomenclature, a bit about anatomy, and look at some MR sequences. If you can, read this article from Spine Journal in 2014, talking about the differences between dispatch, protrusion, and extrusion. Try to avoid local variations as it causes confusions with your fellow radiologists, your residents, your trainees, and also your stage surgeons. If you can, standardize it, surgeons. These are my preference. I use this schematic idea for a dispatch, asymmetrical dispatch, where there's a broad-based protrusion, where there's a focal extrusion through a defect in the annulus fibrosis. To me, an extrusion is where there's a defect in the annulus fibrosis, and also the posterior longitudinal ligament allowing the disc to move out, and you get loss of the nucleus fibrosis. A sequestered disc, which we all know about, is a broken off piece of disc material, usually through a focal extrusion. One tip is to look at this T1 sequence, to look at the through extent of this protrusion. As the T2, sometimes the disc merges with the posterior longitudinal ligament, giving you a false idea of how big the disc extrusion is. For extrusion, look at the sagittal images and look at the splits in the annulus fibrosis, which is this small dark structure here on the inferior aspect and the superior aspect, and also whether there's a split in the posterior longitudinal ligament. Right, going to the nomenclature, this is what we call the central canal zone. This is a subarticular zone because during surgery, when the patient is prone, this is immediately deep to the articular facets. Right, this is the foraminal zone and the extraforaminal zone. And on the axials and MR images, you can see the similar. This area is the central spinal canal. This part is the lateral recess where the traversing nerve root runs. This people call the axial foramen, while I prefer to call it neurasic canal because I can give it a medial, central, or a lateral areas to it. This part is the extraforaminal zone, which you need to evaluate in case the nerve root is affected by any ampullate osteophytes or other structures. Here's the anterior or paravertebral space, and here's the posterior paraspinal space. Right, this is what a normal MR spine or the scan of the lumbar spine is. We usually do a T2 TSE, T1 TSE, T2 term. The terms looking for jaw fractures, whether it's an acute or chronic fracture. Gives an idea of what the disc hydration looks like and the disc height. And then you try and refer to the axial sequences to look at it where the neurasic canals are and where the central spinal canal, and at L5 is 1 where the posterior ilium is. I do advise, seriously recommend doing coronal MR sequences, particularly when the patient has scoliosis. So remember the numbering of 7 cervical, 12 thoracic, 5 lumbar, 5 sacrum, and the coccyx is variable. Unfortunately, not all patients have the correct anatomy. They don't read the textbooks. So you need to do the numbering and counting yourself. We will do a whole spine sagittal localized sequence from skull base down to the sacrococcygeal junction, or perhaps even lower in the pelvic cavity, and we'll number this. Unfortunately, these images are poor signal to noise ratio, making the diagnosis or evaluation of other structures perhaps slightly suboptimal. But you still need to look at other structures on your localized sequence because it is on your image. Okay. And while your text and radiographers will supply a numbered image, I highly recommend that you check the numbering yourself as well. So patients with scoliotic spine can be difficult to number. If you can see 3 sequential sagittal images where the scoliotic portion of the thoracic spine cause some difficulty in the numbering. In this case, refer to any radiographs, particularly the whole spine X-ray and then the lumbar X-ray. And you can see that there are only, if you count down, this is the 12th rib, there's 4 unfused lumbar vertebrae. L5 is sacralized in this instance, and a curve reformat sagittal image confirms that. Okay, so the Castelli classification gives the different variations of the lumbosacral transitional vertebrae. It happens quite commonly and you may not actually realize it when you're scrolling through, but when you get to the L5S1 level, you can see that perhaps one transverse process is larger than the other, enclosing one of the neurasal canals, the anterior neurasal canal, right? And then you will see sometimes this can cause compression of the exiting nerve roots. So in this patient with radicular pain, the patient actually turns out to have a lumbarized S1, a transitional S2, and a vestigial S2-3 disc. So this, if you don't number properly, your surgeons may actually go in to operate on the wrong level, right? And this patient actually exhibits a S1-2, right S1-2 nerve root compression, while the left L5S1 and S1-2 nerve roots are not affected. Localizers are also important to assess for other structures. This patient had a malignant ovarian teratoma that was picked up on the MR localizer. Subsequently had plain film checked, which shows tooth-like structures within the pelvic cavity. So this is a true event that happened in one of the institutions in Singapore many years ago. Okay. So we like to put broad saturation bands anterior to the spine, particularly in the cervical region. The dangers of this is that you can actually miss any particular suspicious malignant masses in the areas that saturated out. So you have to be aware of that. Okay, the spinal cord, assesses central spinal canal patency and whether the neurasal canals are patent as well, right? And whether there is a fluid field structure within the spinal cord, which may represent either a syrinx, in this case, a central canal, the normal anatomical central canal in this case, or whether it's post compression gliosis, right? So in this patient with severe compression of the spinal cord at the C1-2 level post foramen, then you can see that is because the C1-2 this joint space is wider, pushing the adductor pec, the dents posteriorly, affecting the clival dents line, and then this further narrows the joint space under the central spinal canal and causing compression of the cord. So the ADI index is important. You should know the values. In CT, usually actually less than 2 millimeters. Okay, so the Mayerding classifications for spondylolistheses divides S1 into 4 parts, and the grade of the listheses is depending on whether it's 25%, 50%, 75% subluxed anteriorly or posteriorly. Okay, so grading is important. In instances of anterior listheses, the neurasal canal at that level is actually distorted, becomes much more flattened. It's not as tall as previous. It means that the exiting nerve root now courses over the intervertebral disc, which is uncovered and is more prone to compression and compromise. Severe subluxation is also common in the lumbar spine, especially patients with scoliosis. And it can happen in both the coronal and the sagittal planes. So, right. So in this case, we have a left lateral disease of L3 on L4. So the standard nomenclature is the vertebral body above over the vertebral body below. On the coronal, you can see that the exiting nerves are distorted because of this, and it impinges on the uncovered disc. Then decide which side is the right side, and whether the spinal canal is affected as a result. So in the patients with scoliosis, you can see the positioning of the coda equina shifts. As we scroll down to the next level, is now more in the right side of the decentral spinal canal. That is important for your surgeons. Spondylolysis can be difficult to pick up on MR, so always try and refer to the X-rays if you can. And they can make patient more prone to having nerve root compression within the neurasal canals. In this case, on this bilateral L5 spondylolysis, I can see a very nice cleft in the pars articularis where the defect is. Right, so we look at the subdisc, right? This is just a focal posterior central disc protrusion under the intervertebral disc, under the posterior longitudinal ligament. Here, this is mild posterior disc bulge. At C5-6, you can have slightly more extensive disc protrusion posteriorly, and at C6-7, there perhaps seems to be a structure appearing in the left half of the central spinal canal. If you look at the more lateral slice on the sagittal, it is actually a large disc extrusion that is affecting the central spinal canal and the left neurus canal. If we go back to C5-6 level, the narrowing or stenosis at this level may be due to the degenerate ankle-vertebral joint. So it's all about the disc, really. So where can the intervertebral disc go? The answer is anywhere it wants to. Right, it can go posteriorly, pushing out the posterior longicular ligament and the anterior epidural fat, as in this case remains under the posterior longicular ligament. Or it can go laterally or obliquely in the posterior lateral direction, where in this case it comes out and it lifts the posterior epidural fat, posterior longicular ligament, and it can either extend into this neurasal canal or moves into the central spinal canal. More worrying is the one that goes through the epidural fat, splits the posterior longicular ligament, and herniates through the epidural longitudinal ligament into the anterior aspect of the spinal canal. And this one, the surgeons don't really like to operate on because it's fraught with difficulty. And you can see here where the split in the posterior longicular ligament is and this herniation through. And here's a nice example of that, where it's now affecting the spinal cord, which is now pressed against the lamina. Right, so difficulty also differentiating between an intervertebral disc or a nerve root. And this 35-year-old, we have to decide, what is this? Okay, is it a nerve root or is it a disc? All right, I'll say that the disc is this one, where it's not as hypointense as the disc fragment. And if you go to the level above, you can see that this is where the disc extrusion is, and it's actually extended caudally. Same thing in this patient. You can see that almost entire neurasal canals occupy the disc, and then you have to decide where the nerve root is as well. So you have to review the images very carefully for that. Right, and in this instance, is this a disc or a nerve root? Unfortunately, in this protrusion, actually it is an annular fissure. It's a horizontal annular fissure and it's close to the central part of the disc. Right, patients can have too much fat in the epidural space. Epidural lipomatosis is a known entity, and it can cause compression on the spinal cord, and you have what they call the equina and affected nerve root as well, because reduce the space available for the nerve roots to move. This fat tends to be fairly hard, and it's not as elastic as the fat that is contained within the ligamentum flavum. Okay, so sequestration, or where this portion has moved out. In this case, is a nice illustration where the sequestered disc actually has moved in lateral to the cord and then into the posterior aspect of the spinal canal. Okay, but not everything is a sequestered or sequestrated disc. Okay, both spelling are allowed. You can have a neuroma. Don't mistake it for this. If you give contrast, you enhance mildly. DWI may have some degree of fluid restriction, and it should be high on the ADC maps, right? And once you on this axial corresponding, you can see the enhancing lesion. Then, okay, so also refer to X-rays. Okay, so if you lost the normal vertebral end plate outline, where there's erosion or rounding, abnormal rounding, it could be due to this, and all the disc space is narrowed or collapsed, and consider infection or malignancy. Okay. Meds are another entity. For this case, the only provided history was back pain. They did not mention the patient had primary lung adenocarcinoma. So when we did the MRI and the X-rays, X-rays just shows an osteoporotic spine with a compression fracture. MR shows that this is more likely to be pathological in nature due to the marrow replacement. Again, patients with vague back pain and weight loss and stuff. In this case, with the mottled, variegated appearance of the bone marrow within the vertebral bodies, involving almost every single marrow vertebral body. This is likely to be a case of multiple myeloma, and is confirmed to be. Right, let's stay with radiographs again. Patients with dull back pain, no history of trauma, consider infections. In this case, at L5, the anterior inferior corner is rounded and lost, and this is like the history of TB. So this was diagnosed eventually as TB, spondylolisthesis. And you can see the extensive progression over time, just within 1 month, with destruction of the vertebral body and abscess formation in the paravertebral space, common for TB. All right, so if we look at the hardware at the back, sometimes our surgeons do like to put stuff into the vertebral space, and the patient presents with back pain. You can see the markers of the interbody spacer devised here, and the horizontal portion actually protruding into the spinal canal. Refer back to the immediate post-operative radiographs if you can, or any earlier radiographs. You can see that this spacer actually was displaced, but now has started shifting posteriorly. And when on MRI, you can see it protruding into the spinal canal, or even the neuralizing canal, and compressing the nerve roots and causing problems. So they'll need revision. The posterior marker must be at least 2 to 3 millimeters from the posterior margin. Sometimes the posterior marker stays in place, but where it's inserted, you get actually bony or osseous hypertrophy or scar tissue at the side that actually causes the same degree of compression on nerve roots. Sometimes surgery does not quite successful, especially when in the case of the minimally invasive microdiscectomy or sacrosterectomy, where the surgeons cannot close the portal. So they have to leave the portal open so that this can actually protrude or extrude out through that defect. And that's what happened in this post-surgical case. But mind you, do not say that surgery failed. The surgeon will not be very happy with you. Okay, so how do we decide whether it's cyst or cyst, right? So in this one, these are synovial cysts on the degenerative facet joints, all right? If they point laterally, it's fine. They can point into neuralizing canal, okay? Or they can point posteriorly, okay? Or they can be more centrally located, right? Then you have the common talar for perineal cyst, which is around the nerve roots, and don't mistake those. And then there are other things like, AVM, schwannoma in the left foramen, or cystic neurofibroma. So cystic structures should be treated with caution as well. Talar cysts, quite incidental finding, fairly common, usually doesn't cause any issues. We divide them into preforaminal, transforaminal, or postforaminal. Okay, unfortunately, in this patient has a transforaminal talar cyst that is affecting the nerve root above. And you need to communicate this to the surgeon. So always have a look at the sacral neuralizing canals as well, and not just stop at L5 as well. In this patient with vague back pain, if you look at the radiograph, you can see that the anterior sacral foramen is actually larger than what you expect it to be. This patient actually has bilateral trans and postforaminal talar cysts. You need to pick this up and mention a report in case surgeons come along and poke it and you get the CSF leak into the peritoneal cavity. Right, just the facet synovial cyst can cause problems if it extends into the spinal canal or the neuralizing canals through the anterior portion of the facet joints. And in this instance, this one is now protruding into the spinal canal and affecting the coda equina. In this case, it was strangely medially located in the center aspect and pushing the nerve roots or the coda equina anteriorly. Patients with non-specific back pain, look at the sacrum. 85-year-old actually now has a insufficient fracture of the entire sacrum, leading to a back pain. This was almost missed because the radiologist was concentrating on the L4-5 level in anterior anestheses. So in spine imaging, there's a lot of pitfalls. you can make diagnosis and stuff as long as you learn from your mistakes. Be aware of the ways the disc can protrude, extrude, and move. And numbering is very, very important. Use both the axial and sagittal sequences. And if you can, add coronal sequences, particularly when the patient has scoliosis. And consider contrast medium for any masses that you can see. Okay, so with that, my talk is over. Thank you very much for your attention.
Thank you, Dr. Stephen Wong, for your excellent and interesting presentation. Now we move to second speaker. Our second speaker is Dr. Ho Chi Long. Dr. Ho Chi Long is a senior consultant radiologist of Sengkang General Hospital, Singapore, and he will present the topic about the spinal cord. Dr. Ho Chi Long, the time is yours.
Good afternoon, ladies and gentlemen. My talk today is on non-traumatic spinal cord lesions. I have no disclosure. Non-traumatic spinal cord lesions can be divided into neoplastic conditions and non-neoplastic conditions. I'll go through a list of conditions with the patterns of changes on MRI. Firstly, neoplastic spinal cord lesions. On this plain radiograph, there are scalloping of the posterior vertebra. This is called the posterior vertebral scalloping signs. MRI shows tumor in the intraspinal canal, causing scalloping of the posterior vertebra. These conditions are, one of them are NF1, where there are intradural neurofibromas, and thoracic meningiomas. Others are intramedullary tumors or gliomas, glioneurgliomas, and astrocytomas can also do that. It can also be seen in non-neoplastic conditions. Posterior vertebral scalloping signs in chronic raised intracranial pressure, such as communicating hydrocephalus, or dural ectasia due to Marfan or Ehlers-Danlos syndrome, or congenital skeletal disorders, such as achondroplasia and mucopolysaccharidosis. Another signs on MRI of neoplastic lesions are target signs. These are plexiform neurofibromatosis, and each of these lesions has got a central low T2 signal, also low enhancing lesion in the central but peripheral high T2 signal. These are seen in neurofibromas, NF1, which has propensity for malignant transformation, also in schwannomas. Kissing tumor signs or mirror image signs. Again, plexiform neurofibromatosis. The tumors are closely abutting each other, such as kissing tumor appearance or mirror image appearance of the tumors. Rim and flame signs on MRI post-contrast, where there's intense thin rim of peripheral enhancement of the lesions within the spinal cord, may appear as ill-defined lesions with flame-shaped pattern of enhancement at its superior and inferior margins, like here. This sign is highly specific for intramedullary metastasis from a non-CNS origin. Hemosiderin cap sign, where intramedullary tumors having a cap of T2 hypointense rim at the cranial or caudal part of the tumor due to previous intratumoral hemorrhage, like this ependymomas here, having low T2 signal at the caudal and cranial part of the tumors. It can also be seen in hemangioblastomas and paragangliomas. Pitfalls is that post-operative spine with hemosiderin deposition may mimic the appearance. Sugar coating of frosting signs indicates diffuse leptomeningeal enhancement along the cord, cauda equina, including leptomeningeal carcinomatosis with multifocal seeding of malignant cells These cells may originate from primary tumors of breast, lungs, GI, or primary CNS tumors such as medulloblastoma, ependymoma, pinocytomas, primitive neuroectodermal tumors, or malignant melanomas, lymphoma, and leukemia. Infiltration of leptomeninges can be associated with poor prognosis. You see the enhancement and nodular thickening of the tumors within the spinal cord. In meningoencephalitis, there are glycoproteins released by bacteria causing breakdown of blood-brain barrier with subsequent leakage of contrast from the vessels onto the cord surface, resulting in leptomeningeal enhancement. Other conditions masquerading sugar coating or frosting signs are inflammatory polyneuropathy, mimicking this condition in SLE, as well as Guillain-Barré syndrome, where there is thickening and enhancement of the spinal nerve roots and cauda equina. Intracranial hypotension with diffuse intracranial and spinal pachymeningeal enhancement may also mimic that condition. Salt and pepper signs is seen in highly vascularized tumors, for example, in paragangliomas and hemangioblastomas, where the flow voids resembling the pepper within the post-contrast image of the lesion. Claw sign is seen in intramedullary tumors, where the tumors displacing the normal spinal cord tissue to the periphery, resembling a kind of claw appearance. Another intramedullary tumors causing displacing the peripheral rim of normal tissue surrounding it, giving a claw appearance. Intramedullary tumors with claw signs, for example, in this MRI image. And if there's intramedullary tumor with extramedullary extension, it gives a snowman sign. Distinguishing intradural extramedullary from extradural tumors are important. Extradural tumors forms an obtuse angle with a surrounding CSF. Resembles a marble or object below the carpet. The carpet being the dura, and the tumor, the marble, and surrounding CSF. As what we can see here, the tumor forming an obtuse angle with a surrounding CSF. Intradural extramedullary tumors forms an acute angle with the surrounding CSF. Resembles a marble or object above the carpet. Here, the marble, the tumor, in this case a meningioma, and it forms an acute angle with the surrounding CSF. This is a case of schwannoma, forming an acute angle with the surrounding CSF. In MRI with spinal tumors, you can see in the summary expanded cord, claw signs, and some of these conditions of intramedullary tumors. If it's formed a snowman sign, it has gotten an extramedullary extension, like in hemangioblastoma. The CSF are compressed, and it forms an acute angle with the tumor and CSF. You can see that this in intradural extramedullary tumors, such as meningioma, schwannomas. Whereas CSF space compressed, and tumor forms obtuse angle with the surrounding CSF, as is marble under carpet in extradural tumors, which are seen in Ewing sarcoma, myeloid sarcoma, and metastasis, as well as venous plexus, as well as lipomatosis. Non-neoplastic intramedullary diseases are a huge list of lesions. Firstly, compressive ischemic conditions. Snake eyes, owl eyes, and fright eyes. What has all this in common to do with the spinal cord? Snake eyes are bilateral symmetrical circular ovoid hyperintense lesions on axial T2 of the cords. And primaries occurs in the compressive myelopathy with mechanical compression. May result in venous infarction and cystic necrosis of cord. Sagittal T2 may shows a linear pencil-like chord signal. And on axial, you will see a snake eyes appearance within the chord. As in pancake sign, there is T2 hyperintense, an enhancement of the chord at the maximal stenotic site of the spinal canal. And on post-contrast, there may be a transverse band less than one vertebral segment associated with disruption of blood-brain barrier of the chord at the point of maximal stenosis. It is also suggested to be a cause of myelopathy. Again, owl's eye sign, ovoid hyperintensity involving the anterior horn cells of the chord, gray matter with corresponding restricted diffusions in cystic necrosis secondary to infarction or ischemia. As we see here in DWI and ADC changes within the chord. On sagittal T2, there is cytotoxic edema extending over several segments along the chord. Acute chord infarction of the cervical and thoracic segment is often attributed to occlusion of anterior spinal artery and artery of Adam-Kiewicz, respectively. Scalpel sign you see in a focal deformity of the thoracic spinal cord with anterior displacement of the spinal cord by enlarged dorsal CSF. And this condition is in dorsal thoracic webs that can be associated with syringomyelia, like here. This produces a characteristic deformity of the cord resembling the shape of a scalpel on sagittal T2 weighted image. This sign is associated with dorsal thoracic arachnoid webs that extends to the pile surface of the spinal cord. Pathologies resembling thoracic arachnoid webs are ventral cord herniation or dorsal arachnoid cyst and adhesive arachnoiditis, where there's reverse scalpel sign, as we can see on this sagittal and axial image. Y sign in spinal epidural lipomatosis, where excessive fat compresses the thecal sac, causing a trifid-shaped appearance, letter Y, of the thecal sac. Although mostly asymptomatic, can be associated with spinal dysraphism. In this case, where the fat surrounding the thecal sac giving a Y-shaped appearance. It can be divided into 4 categories involving exogenous steroid use, obesity, endocrinopathy, and endogenous steroids, and non-obese idiopathic conditions. These can occur in those undergoing steroid therapy, Cushing's syndrome, carcinoid tumors, and hypothyroidism. Pitfalls is that excessive epidural fat compressing the thecal sac, occasionally causing a square shape rather than Y-shaped appearance. Leptomeningeal diseases may also mimic this condition, this Y shape. Vascular lesions, for example, in black butterfly sign, where there is symmetrical dark silhouette in dorsal medulla and central gray matter of the cord, accompanied by dilated perimedullary veins. This sign is unique to the spinal cord. Sorry, this sign is uniquely in spinodural AVF, where there's intramedullary hemorrhage secondary to venous congestion or hypertension. There's, as what we can see here, cord edema and the dural AVF. Intramedullary cavernoma giving a popcorn sign or mulberry sign. These are well-defined lobulated lesions with heterogeneous center and surrounding T2 hypointense ring. These conditions, cavernoma is due to thrombosis, fibrosis, calcifications, and breakdown of blood products. Inflammatory conditions of the cord, firstly, open ring sign, open ring T2 hyperintensity or enhancement within the spinal cord, as what we can see here, a C-shape or horseshoe shape. The enhancing or closed component of the ring is thought to represent advancing front of demyelinating diseases that favors the white matter component of the lesions, whereas the open part of the ring points towards the gray matter of the cord. Multifocal asymmetric involving short segments within the cord, highly specific for inflammatory demyelinating conditions such as MS and ADEM. And this sign can differentiate demyelination from other malignant processes or other infective processes. Inverted V sign or kangaroo or rabbit sign, rabbit ear sign, a T2 hyperintensity extending along the dorsal column, typically in subacute combined degeneration of the cord, which is most common manifestation of metabolic derangement such as B12 deficiency. And inverted V sign is also present in individuals with nitrous oxide abuse intoxication and copper deficiency. Hyperintense signal in the posterior funiculars of the spinal cord resembling a letter V. Recognition of this sign is important for early diagnosis and further treatment of these conditions. Other inflammatory conditions such as MOC, autoimmune associated diseases, myelin oligodendrocytes glycoproteins is a glycoprotein located on myelin surface and found exclusively in CNS. And there are autoimmune antibodies against MOG, against the MOC. And this MOC autoimmune disease can occur in all decades, but more commonly in women than in men. MRI features of MOC IgG myelitis are T2 hyperintensity crossing more than 3 vertebral segments, and it gives a H-shaped appearance with cord edema. Sagittal also gives a sagittal T2 hyperintensity with cloudy appearance within the cord and involves more than 50% of the cord. These lesions also typically occurs in the corners with clouded light enhancement of the cord within the corners. Aquaporin 4 IgG associated disease. Here, aquaporin 4 is the most abundant channels in mammalian CNS, highly expressed in membranes of astrocytes, astrocytic end feet of interfaces between blood, CSF, and the brain parenchyma. Typically in neuromyelitis optica spectrum of diseases where it's inflammatory disorders affecting the brain, optic apparatus, and spinal cord. Majority of NMOSD patients has autoimmune antibodies against aquaporin 4. And NMOSD patients are either positive or negative for aquaporin 4 antibodies. Bright spotty signs in these conditions of NMO spectrum of disease, where the central spinal cord has T2, pronounced T2 hyperintensity, giving a bright spotty appearance. Classic appearance NMO spectrum of disease, triad of optic neuritis and longitudinal extensive myelitis, and positive anti-aquaporin 4 antibodies, as well as a bright spotty sign associated with positive antibodies against aquaporin 4. Conclusion: MRI patterns and signs can increase radiologists' confidence in diagnosing spinal cord lesions, hence allowing for early diagnosis and treatment of patients' conditions. Here are the references. Thank you very much for listening to this talk. Thank you.
Thank you, Dr. Ho Chi Long, for your excellent and informative presentation. Okay, we move to our third speaker. Our third speaker is Dr. Lee Jun Si-wan. He is a consultant radiologist of Sengkang General Hospital, Singapore. And Dr. Lee Jun Si-wan will present about the topic spine trauma imaging. Dr. Lee Jun Si-wan, the time is yours.
Good afternoon, everyone. My topic is on spine trauma imaging. I have nothing to disclose. Here is the outline of my talk. The anatomy of the upper cervical spine is unique in morphology and function, as shown below. The subaxial spine shares similar anatomical features. It can be divided into columns or stabilizers. Here is an example of Dennis' three-column concept of the spine. The blue portion indicates anterior column, including ALL, anterior two-thirds of the vertebral body, and anterior two-thirds of the disc. The green portion is the middle column, which includes the posterior one-third of the vertebral body, posterior one-third of the disc, and PLL. The yellow portion is the posterior column. Stabilizers are also known as tension bands. The anterior tension bands include ALL, disc, and PLL. The posterior tension band includes fasciculum capsules, ligamentum flavum, interspinous ligament, and supraspinous ligament. The posterior tension band is also known as the posterior ligamentous complex. The anterior and posterior tension band together is also known as discoligamentous complex. Clearance of the spine is important for patient management in the trauma setting. One of the most widely used criteria is nexus criteria. It has 5 components, including no posterior midline cervical tenderness, normal level of alertness, no intoxication, no focal neurological deficit, and no painful distracting injuries. If all 5 criteria are met, there is no requirement for imaging. It has high sensitivity up to 99% and high negative predictive value up to 99.8%. However, if the patient's age is more than 65 years, imaging is usually required regardless of the risk. The other widely used criteria is called Canadian C-spine rule. It has 3 components, which are high risk factors, low risk factors, and ability to move the neck actively. If there's no high risk factors and the patient is able to move the neck actively, there's no imaging required. However, if there's high risk factors present and patient has limited range of movement of the neck, imaging is indicated to assess underlying cervical spine injury. It has high negative predictive value of almost 100%. Thoracolumbar spine clearance has no widely used or validated criteria. However, the basic principles are similar to those of the cervical spine. Here are a few examples of thoracolumbar spine clearance criteria proposed by some authors. Moving to imaging modalities. Radiography is the primary screening tool for children younger than 14 years old. It has low sensitivity and low specificity in patients older than 14 years old. Radiography is reserved for those with low suspicions of spine injury or when CT is not available. It requires standard views, which are lateral and AP views, and open mouth view is usually used in the cervical spine. Multi-detector CT is the main workhorse of initial traumatic spine imaging. It is fast and easily accessible. It also has higher diagnostic accuracy than radiography. It is modality of choice for patients older than 16 years old who meet criteria for imaging. In the thoracolumbar spine, the images are usually reformatted from CT pan scans. MRI has high sensitivity and high specificity in detecting ligamentous injuries. It also has high false positive rate. For example, in type 2 odontoid fractures as shown in this CT image. On MR stir sequence, the fracture line is hardly seen and there is minimal edema in the bone marrow. Many cases with positive MRI finding but negative CT finding do not require surgical intervention. Therefore, MRI is usually considered a complementary assessment for certain set of patients. It is mainly used for those who have persistent pain or neurological deficits but no abnormal CT finding. Those cannot be examined for at least 48 hours, and those with unstable spine for treatment planning. Patients with clinical or imaging findings suggestive of ligamentous injuries, and if there is significant injury morphology on CT scan, MRI is usually indicated. Moving to cervical spine injury. Cervical spine injuries can be divided into atlas fractures, axis fractures, and subaxial cervical spine fractures. Atlas fractures account for up to 13% of all acute cervical spine fractures. Up to 40 to 44% of atlas fractures are associated with axis fractures. The mechanism is axial loading. The commonly used classification is Euler classification. This is a type 1 atlas fracture, which involves only the anterior arch. Type 2 fracture involves only the posterior arch and is usually bilateral. Type 3 fracture involves both the anterior and posterior arches. It is equivalent to the classic Jefferson-Bruce fracture. The type 3 fractures can be further divided into type 3A and type 3B. Type 3A fracture shows intact transverse atlantal ligament, whereas in type 3B fracture, the transverse ligament complex is disrupted. If the sum of the lateral mass displacement on radiography exceeds 6.9 mm in an atlas burst fracture, the transverse ligament is probably torn. This is called rule of Spence. Dickman classification further classified different types of transverse ligament injury. In type A, the ligament is torn either at the insertion point or in the mid portion. In type 2, the bony attachment of the ligamentous is also injured. Coming back to Euler classification, type 4 atlas fracture is a lateral mass fracture. And type 5 is an isolated C1 transverse process fracture. When the fracture line extends to the transverse foramen, vertebral artery injury needs to be excluded. Axis fractures, they account up to 20% cervical spine fractures. There are 3 distinct patterns: odontoid fractures, hymen fractures, and axis body fractures. They have high rate of neurological deficits, up to 8.5%. Odontoid fractures are the most common axis fractures, up to 59% in axis fractures. The classification is proposed by Anderson and D'Alonso in 1974. Type 1 odontoid fracture is considered stable. It is an oblique fracture through the tip of the odontoid process. It has good bone fusion rate with conservative management. Type 2 fracture is the most common type of fracture, which is usually unstable. It occurs at the junction of the odontoid process and the axis body, which is considered as a watershed zone. Therefore, the rate of non-union of the fracture can occur up to 67% if the fracture fragment displacement is more than 6 mm. Type 3 fracture is intermediate in incidence and is considered potentially unstable. The fracture extends downwards into the cancellous portion of the axis body. It has good healing with conservative management such as immobilization. Also, I need to take note there are certain entities that can mimic odontoid fractures. For example, in this case, the patient has os odontoideum. Another example of os terminale, which can also mimic type 1 odontoid fracture. Moving to hymen fractures, they're also known as traumatic spondylolisthesis of the axis. They account for 22% of axis fractures and 4% of all cervical spine fractures. The mechanism is compressive hyperextension or distractive hyperflexion. The fracture pattern can be typical or atypical. Typical Hammond fractures involve bilateral pars interarticularis. The classification system is proposed by Effendi and later modified by Levine and Edwards. Type 1 Hammond fracture is hyperextension compression injury, which shows less than 3 mm anterior translation. Type 2 Hammond fracture is a compressive hyperextension or distractive hyperflexion injury, which shows severe angulation of more than 11 degrees and severe anterior translation of greater than 3 mm. Type 2A is a subset of type 2 fracture, which is a distractive hyperflexion injury, which shows severe angulation without translation. The anterior longitudinal ligament is usually intact. Type 3 fracture is a distractive hyperflexion injury with facet fracture dislocation and usually bilateral facet dislocation. The management of typical Hammond fracture usually involves external cervical immobilization such as halo vest. Atypical Hammond fractures occur through the posterior cortex of the axis body on one or both sides. It has a wide range of incidence of up to 74%. It also has higher incidence of neurological deficits compared to the typical Hammond fractures, probably due to compromise of the spinal canal by the fracture fragment. Surgical fixation of atypical fractures may be required. An example of atypical Hammond fracture involving the right posterior cortex of the axis body. Note the posterior displacement of the fracture fragment in the sagittal vein. Axis body fractures include non-odontoid non-Hammond fractures. In fact, Anderson de Alonso type 3 odontoid fractures are actually axis body fractures. It accounts up to 32% of axis fractures. Isolated lateral mass, pedicle, or transverse fractures are also seen. These fractures are often inherently stable and treated non-surgically. Here's an example of isolated right lateral mass fracture of the axis. Moving to subaxial cervical spine injury. Subaxial cervical spine injury accounts for 65% of cervical spine fractures and 75% of dislocations. There are four main mechanisms: compression, hyperflexion with posterior distraction, hyperextension with anterior distraction, and translation or rotation. There are few classification systems. The two commonly used ones are cervical spine injury severity score and cervical spine subaxial injury classification and scoring system. Cervical spine injury severity score system is a 4-column model. It includes anterior column, right and left pillars, and posterior osseous ligamentous complex. There are isolated or complex injury within the category. 0 to 5 points are assigned to each column. The total score range from 0 to 20. If the score is 7 or more, surgical intervention is required. It shows good inter- and intra-observer reliability in the original study. However, neurological status and MRI findings are not included in this system. Subaxial injury classification and severity score is similar in concept to that of TLICS. It is determined through plain radiograph, CT, and MRI findings. There are three components: morphology, integrity of ischioligamentous complex, and neurological status. If the total score is less than 4, no surgery is required. If it is more than 4, usually surgical intervention is indicated. If the score is 4, it is indeterminate. The surgeon will decide if the patient needs surgery or not. A few examples of subaxial cervical spine injury. Here is a flexion teardrop fracture. Note the triangular fracture fragment at the anterior inferior lip of the vertebral body. It is most common in the lower cervical spine, for example, C5 and C6. The mechanism is flexion and compression forces. It usually has a larger retropulsed posterior fragment which can cause cord compression. Posterior ligamentous complex distraction can occur in some cases. Flexion teardrop fracture is usually considered highly unstable. Another more severe type of flexion teardrop fracture. So this patient has severe flexion compression with posterior distraction. There is an anterior wedge compression fracture of the vertebral body, teardrop fragment, avulsion fracture of the spinous process, rupture of the facet joint capsule, supraspinous ligament, as well as kyphotic deformity. Here's an example of unilateral facet joint fracture subluxation. The mechanism is probably flexion, posterior distraction, and rotation. There's also tension band injury. On MRI, there is rupture of the anterior longitudinal ligament and ligamentum flavum. A more severe type of unilateral facet joint fracture subluxation. A different patient shows similar fracture pattern on CT scan. However, on MRI, there's evidence of cord contusion and cord edema. An example of extension teardrop fracture. The arrow points to the small triangular fracture fragment. The fragment is usually smaller than the flexion type. Anterior longitudinal ligament injury is common, and there's usually a widening of the anterior disc space. Many patients, up to 80%, have acute central cord syndrome. Here's an example of hyperextension injury, which shows associated cord edema and possible hemorrhage. Torn anterior longitudinal ligament, posterior tension band edema. An example of isolated laminar fracture, which shows the fracture line extends from the lamina into the spinous process. It is considered rare. The mechanism is hyperextension force. It is considered stable. Here's an example of isolated right C4 transverse process fracture. It is quite rare, and many people consider it is clinically insignificant. It results from lateral loading plus minus rotation. However, if the fracture extends to the transverse foramen, there's high risk of vertebral artery injury. And up to 63% of vertebral artery injury are asymptomatic. Now let's move on to thoracolumbar spine injury. Thoracolumbar injury classification and severity score, TLICS. Similar to SLICS, it also includes 3 components. Points are assigned to each component. The imaging injury morphology of the vertebral body indicates mechanical stability of the spine. The integrity of the posterior ligamentous complex indicates the long-term stability. If the total score is 3 or less, no surgical intervention is required. If it's 5 or more, surgical intervention is needed. And if it is 4, it can be managed either conservatively or surgically. Next is AO spine classification, which is proposed recently by Vicaro in 2013. It is an integration of Mago system and TLICS. It is primarily based on CT scan. There are 3 types of injuries. Type A is compression fracture, Type B is tension band injury, and Type C is displacement translational injury. Grading of neurological deficits is also included, and there are case-specific modifiers. In type A injuries, there is failure of the anterior structures under compression, and the posterior tension band is intact. There are 5 subtypes. Type A0 is either no or only minor fractures, such as fractures in the spinous or transverse process. Type A1 is wedge or impaction fractures of a single end plate. Type A2 is split or pincer type fractures involving both end plates. Type A3 is fractures involving a single end plate and posterior vertebral wall, also known as incomplete burst fracture. Type A4 involves both end plates and posterior vertebral wall. Type B injuries is failure of the anterior or posterior tension band. There are 3 subtypes. Type B1 is monosegmental transosseous posterior tension band injury, also known as chance fractures. Type B2 is posterior tension band disruption with a type A fracture. The type A fracture is classified separately in the report. Type B3 fracture is hyperextension injury through anterior tension band, resulting in a hyperextended position of the spinal column. The ALL in type 3 injury is disrupted. Here is an example of T1011 potential type B3 injury. The patient later developed hyperextended deformity. Type C injuries are the most severe type. They are segmental injuries due to failure of all elements leading to dislocation or displacement of the segments. There are 2 modifiers. M1 is used to designate fractures with an indeterminate injury to the tension band based on spinal imaging. M2 is used to designate a patient-specific comorbidity such as ankylosing spondylitis, rheumatologic conditions, dish, osteoporosis, and etc. What is the AO classification in this case? In L2 vertebral body, there is complete burst fracture, which is assigned A4. And also note in L1, there is single lower end plate fracture, so it's assigned A1. There's also edema in the posterior tension band on MRI. The arrow points to disrupted ligamentum flavum and inter- and supraspinous ligaments. So there is type B2 injury at L1-2 level. Neurological status in this case is N3 due to incomplete cord injury. So in summary for this case, there's type A4 injury at L2, type A1 injury at L1, type B2 injury at T12 L1, and the neurological status is N3. Take-home messages. Know your anatomy. Be familiar with Danish 3-column concept and tension bands. Nexus and Canadian C-spine rules are very useful in spine clearance, which can also help to avoid unnecessary imaging. Be familiar with mechanisms and common patterns of spine fractures. SLICS, TLICS, and the newly proposed AO spine TLIC systems are very useful, not only in classifying spine fractures, but also in guiding treatment. Thank you for your attention.
Thank you, Dr. Lee Jin Xuan, for your excellent and informative presentation. Our last speaker is Dr. Daniel Chan. Dr. Daniel Chan is a senior consultant of Orthopedic Surgery Department, Sengkang General Hospital, Singapore. Dr. Daniel Chan will deliver a topic about spine imaging, a spine surgeon's perspective. Dr. Daniel Chan, the time is yours.
Stephen has kindly asked me to give this talk at your esteemed meeting. I wonder what I can really tell you that you wouldn't know already. So I thought maybe the thing to do is for me to give away my trade secrets so you can understand how a spine surgeon thinks and how I use and interpret the various radiological modalities, and hopefully that may be useful. There are limited surgical options available to the spine surgeon. One is decompression, which is for neurological presentation. This can be direct, removing the compressive pathology right next to the neural tissue, or indirect by unkinking this bony canal, which requires the other armamentarium of stabilization, usually with instrumentation. Stabilization generally means a fusion of an unstable bony column with correction of local, regional, or global deformity, and may be applicable to axial pain from specific causes. These concepts are applied to all pathologies of the spine. The spine is an articulated bony tube with nerves inside. Presenting complaints are axial pain, deformity, stiffness, and then when the articulation or bony tube fails, the consequence to the neural structures within are nerve pain, motor and or sensory deficits. When presenting complaint is solely axial pain, precise anatomical diagnosis is difficult. The main aim really is to exclude ATIP, which is abdominal retroperitoneal causes, tumor, infection and inflammation, and trauma. The fine-tuning of the benign but troublesome conditions such as facetogenic, discogenic, pain, spondylolisthesis, spondylolysis, and other mechanical causes become a diagnosis of exclusion. Neurological presentation are radiculopathy and or myelopathy, depending on the location, and can be more readily identified from the clinical pictures and confirmable with imaging. How rapidly progressive is important. Expedient imaging will be mandatory. Prime example is acute cholic spinal syndrome and acute spinal cord compression, for example, metastatic compression. On this clinical diagnosis framework, I then look at what armamentarium my radiological colleagues have to help establish the diagnosis or even treat the pathological condition demonstrated. Today, we will focus on diagnostic imaging modalities, but we'll not go into myelography or nuclear medicine. Interpretation of X-ray is still based on clinical features, depending on whether it is mainly axial pain or neurological. In the context of axial pain X-rays are not all that useful other than demonstrating the obvious osseous or discoligamentous disruption in excluding tumor, infection, inflammation, and trauma. A normal X-ray, however, does not completely exclude these conditions, but with clinical features, it may be sufficient and reassuring. Completely normal plain X-ray, however, with no neurological symptoms means I'm unlikely to have a surgical solution. Likewise, a spine with multi-segment degenerative changes in a patient with only axial pain also means I'm unlikely to have a good surgical solution. Isolated discopathy may be the only anatomical axial pain source, and maybe a candidate for stabilization procedure is sufficiently bothersome, provided that MRI shows the rest of the lumbar spine is normal. There may be an option of fusion of the isolated discogenic pain source. The diagnosis is a process of elimination. Whether one does fine-tuning with provocative discography or facet blocks will be a moot point. Spondylolisthesis, spondylolysis per se may also be asymptomatic, but when there is a relevant neurological presentation, may suggest a diagnosis. Degenerative spondylolisthesis generally causes traversing nerve root entrapment, for example, L5 radicular pain for lateral recessed stenosis in L4-5 degenerative spondylolisthesis. In isthmic spondylolisthesis, the exiting root is generally entrapped. In this L4-5 spondylolytic spondylolisthesis, the exiting L4 root will be usually caught in the flattened neural foramen. Further displacement, standing or flexion extension view implies segmental instability, and stabilization surgery will be required if surgery is deemed warranted. For neurological presentation with radicular pain or claudication, an MRI is often done before even X-rays nowadays. The MRI may show mild or no spondylolisthesis and mild or no root compression. However, if a sizable facet gap is seen, a spondylolisthesis is expected on weight-bearing X-ray, as in this example. If the L5 radicular pain comes on with standing and walking, the mechanism will be dynamic lateral recessed stenosis. So an MRI demonstrating no significant neural compression doesn't exclude it. Weight-bearing X-ray demonstrating a spondylolisthesis not seen on sagittal cuts on MRI would provide a diagnosis. A large facet gap or fluid effusion sign would suggest a mobile and unstable degenerative spondylolisthesis with dynamic lateral recessed stenosis. Weight-bearing X-ray compared with supine X-ray or dynamic flexion extension views are therefore very useful. For fractures, if minimally or undisplaced, an erect view is also useful in confirming no displacement on weight bearing and allow continual conservative management. It may also pick up occult distal ligamentous disruption causing segmental instability, and it's demonstrated by this case of neck injury following an RTA. Initial X-ray and CT was passed as normal, but an upright X-ray easily demonstrated the distal ligamentous disruption, also the segmental instability requiring surgical stabilization, here with an ACTF and a locking plate fixation. We published a small case series illustrating the usefulness of upright cervical spine X-ray in these circumstances. Likewise, the thoracolumbar spine, erect X-rays are useful in picking up fracture cases that may not do so well treated conservatively. This study from Newcastle showed that 25% of patients treated conservatively subsequently needed surgery, as picked up by increasing local kyphosis and deformity on the standing X-ray. For evaluation of spinal deformity, a whole spine weight-bearing X-ray is needed. The lateral view should include a hip joint so that spinal pelvic parameters can be measured. The EOS machine does have a good overall image in standing position and is also low dose. Supine lateral bending views, however, is still needed to assess flexibility. A supine AP view compared to standing view is also very useful in assessing the effect on weight bearing alone on spinal deformity. CT, to me, is almost as important as MRI for these reasons shown. CT scans are invaluable in trauma to define fracture anatomy and hence the fracture type. The demonstration of the anterior column compression failure is obvious here on the left, but the more important determinant as to whether surgical intervention is needed is the posterior element, as when there is a tension failure, shown here by a transverse fracture across spinous process and lamina. It is a much more unstable situation, and progressive kyphosis is expected without surgical stabilization. CT allows much better assessment of pedicle screw trajectory and pedicle size, particularly in distorted anatomy. It is useful for pre-op planning. If used in this situation, the images will need to be displayed orthogonally along the axial plane at each of the pedicle levels. Although MRI is most useful in tumor situation, it doesn't show whether tumor is lytic or blastic or mixed. This, of course, is important information on the likelihood of pathological fracture. It also assesses the operability, depending on whether vertebra with tumor that may or may not be able to take medical work. The spine on the left is inoperable if there aren't any vertebra that can support instrumentation. But the one on the right is plastic and unlikely to fracture. Here, likewise, in spinal infection, although MRI demonstrates the extent of this TB abscess very well, the bony destruction is much better demonstrated on CT. Here, the CT scan shows that T5 could not be saved and expected to support the structural graft, which in this case is an expandable cage and therefore CT was valuable in planning the anterior column reconstruction. In spinal deformity, that is a rigid deformity, CT scan is also very useful. CT here is valuable in showing the disc space collapse, and in particular the ankylosis. At the apex is also rotational kyphoscoliosis, which is an area normally should be slightly lordotic. But segments above and below are still mobile, as shown by the vacuum sign. Without a complex osteotomy, or in this case, a multiple level anterior release and interbody fusion, one would not be able to correct deformity. In patients with cervical or thoracic myelopathy, differentiating OPLL from osteophytes, OYL from ligamentum flavum hypertrophy is also important, as it changes the complexity of surgery and predicts the likelihood of a dural tear. Here, the CT demonstrates clearly the OPLL, also double layer sign. And sure enough, we had an anterior dural tear during the anterior corpectomy to decompress the spinal cord. Now we come to the most useful modality, the MRI. It is perhaps most often requested for axial pain. However, I'm very selective, as MRI is not diagnostic for axial pain, which more often than not is multifocal, multifactorial, and non-specific. I tend to request mainly for neurological presentation. For axial pain, I predominantly use it to exclude tumor, infection, inflammation, and trauma, and I clinically can't exclude it. In other words, when there are lots of significant red flags waving at me. When there are lots of yellow flags waving at me, it can be counterproductive, and we'll come back to that point. For the purpose of excluding tumor, infection, trauma, a stir image is vital. X-rays here was obvious in showing upper end plate compression fracture. When the patient presented with acute low back pain without a clear history of trauma, dating the fracture is useful, as the X-ray appearance may be old and may not be the pain source. In chronic mechanical low back pain, as outlined before, potential surgical cases will be localized discopathy with sufficient pain severity and disability and a favorable psychosocial profile. Here, the X-ray shows an isolated disc space narrowing. She has no lumbar radiculopathy to help determine the pain source. MRI was done mainly to show the rest of the lumbar spine is normal. It, however, showed an L4-5 discopathy as well, but the rest of the lumbar spine was indeed normal. A 2-level ALIF was subsequently done with good outcome. The most useful and usual reason for getting an MRI scan for me is neurological presentation. Whenever possible, I'll clinically locate the nerve root level or myelopathic level and use the MRI to confirm my clinical diagnosis. Bearing in mind asymptomatic neurocompression is frequent, the most contentious issue is when neurological symptoms are ill-defined and no supportive signs. Root compression seen on scans, asymptomatic cord compression is not infrequent. This recent meta-analysis suggests an asymptomatic cord compression rate of 24%. The symptomatic degenerative cord compression rate was only 2.3%. We often differ when considering severity of lateral recessive foraminal stenosis, also the degree of degenerative changes. Here I would pass the MRI as normal for age, yet it was thought to have moderate to severe left L4-5 neuroforaminal stenosis and degenerative distal vertebral changes. There was no relevant radicular symptom. This patient came through ED with severe low back pain on a background of long-standing back pain and opioid usage. As a surgeon, my assessment of the severity of nerve root compression is often different. Looking at imaging from a surgeon's eyes, I tend to determine whether I can realistically decompress the neural structures. In other words, can I make it better than what is seen? This 32-year-old man presenting with low back pain definitely has constitutional congenital stenosis with short lumbar pedicles. the image reported as showing severe bilateral lateral recessed stenosis is L4-5 and mild bilateral exit foraminal stenosis. I however don't really concur with the severe lateral recessed stenosis reporting, and I don't see any relevant foraminal stenosis. Decompression surgery won't help the axial low back pain, which is the main problem here. An area of confusion for the referring clinician is chordae equina syndrome. Chordae equina syndrome is clinical diagnosis rather than radiological, although there may be gray areas. Acute chordae equina syndrome from a canal filling disc on left is one that needs emergency surgery. But a similar disc herniation without chordae equina syndrome as on the right does not need an emergency decompression. Of course, acute chordae equina syndrome due to tumor compression or other pathology is still important, but they will need more urgent workup before surgery can be decided upon. The contentious issue is the report of chordae equina syndrome in patients with spinal stenosis. By definition, all patients with central spinal stenosis have chordae equina compression, but they don't have chordae equina syndrome. We tend to be contacted in panic by the medical team when an elderly patient is admitted with declining mobility and back pain. And the report comes back describing chordae equina compression, but they don't have chordae equina syndrome. In spinal stenosis, the chordae equina is chronically compressed. The onset is slow, but acute chordae equina syndrome is uncommon. This patient has right L4 and L5 radicular pain, but no clinical signs of acute chordae equina syndrome, although the chordae equina clearly is compressed. Another area of complication is the foramen. I tend to assess the foramen on the parasagittal cut. The T1 image is particularly useful as it shows epidural fat. A foramen with no epidural fat and corresponding symptoms is reliably significant, bearing in mind the high incidence of asymptomatic foraminal stenosis. The nerve normally exits in the upper half of the foramen, so even if the axial image cutting across the disc may show no space between the disc and the facet joint, the nerve root would have emerged above that already and not affected. But if the parasagittal cut shows no fat signal around the nerve root in the upper half, I would be more inclined to suspect it to be clinically significant. This case illustrates bilateral foraminal flattening due to the L4-5 spondylitic spondylolisthesis, but more subtly, there's also a mobile spondylitic spondylolisthesis that is demonstrated on the weight-bearing X-ray. Surgery needed both levels to be addressed, here with a 2-level lumbar interbody fusion, anterior lumbar interbody fusion, to indirectly decompress the L4 nerve root by restoring the foraminal height and further stabilized by posterior pedicle fixation. This again illustrates the importance of a weight-bearing X-ray. Finally, this is an interesting paper from Rajasekharan in Ganga. Though this is done on axial low back pain with no red flags, this is an interesting study on the catastrophizing effect on the MRI report. The study is an RCT with 2 groups of patients. Group A, blue line, was given the factual report verbatim, whilst Group B, orange line, was reassured of the incidental nature of the finding. There is a significant difference between the pain severity, functional status in physical and mental domains with Group B faring significantly better after 6 weeks of the same conservative management. The authors advocate educating clinicians on the potential harmful effect of overuse of MRI and to avoid unnecessary use of advanced imaging. They suggest using clinical reporting as opposed to image reporting to decrease the catastrophizing effect of the report. So in a nutshell, from a spine surgeon's point of view, Plain radiograph is very good demonstrating and quantifying spinal deformity. Weight-bearing views may unveil segmental instability and allows the assessment of the effect of gravity on the spinal deformity. CT is useful for bone anatomy and quality assessment, and good for surgical planning for instrumentation. MRI invaluable in demonstrating the neuroanatomy and soft tissue pathology. The radiological report can have a catastrophizing effect on patients and clinicians alike, and add to the difficulties in managing the anxious and the somatizing patients. That sums up my approach to using the different imaging modalities and my interpretation of the imaging findings. Thank you.
Thank you, Dr. Daniel Chan, for your excellent, interesting, and informative presentation. Now the session is completely finished. Once again, I would like to thank all of the speakers for their sharing. And for all of the participants, thank you for your active participation. Please don't forget to visit the Expo Hall. You can visit the Expo Hall even after the webinar ends. And see you tomorrow for second day of AMS meeting, which is started at 8:40 West Indonesian time. I am Dr. Elisanti signing off. Have a good day, everyone. Goodbye. Thank you very much for your kind attention.